Hello, pleasant good morning to all, or good evening or good night, depending on where you're tuning in from. Welcome to the virtual HPB Surgical Oncology Conference hosted by the Caribbean chapter of the AHPBA. My name is Dr. Amiel Ara, and it is my honor to introduce our chapter president, Professor Shamir Cawich, who will give today's opening remarks. Thank you.
Morning, colleagues. Friends, welcome to the Caribbean chapter meeting for the Americas Hepatopancreaticobiliary Association. I'd like to specially recognize the president of the AHPBA, Professor Timothy Pollock, and past president, Prof. Elijah Dixon. We also have amongst us the president of the Indian chapter of the International Hepatopancreaticobiliary Association, Prof. Shrikhande, and the Canadian chapter of the AHPBA, Professor Sean Cleary. Welcome all and to all other distinguished guests. Now, 2020 has been quite a challenging year. We've seen COVID circle the globe with rapidity and ferocity. It's crippled healthcare systems. It's brought national economies to their knees and significantly disrupted travel globally. And so we weren't able to facilitate the Caribbean chapter meeting in the usual face-to-face fashion, to enjoy social programs and to have physical interaction. But this has given us a unique opportunity to reach more of our members and for increased collaboration with many of our colleagues across the globe. We have attempted to capitalize on this by having a combined meeting with regional associations of the AHPBA. We've collaborated with the Americas Hepatopancreaticobiliary Association, and in specific the Canadian chapter, as well as the Pacific Regional Association of the AHPBA, and in specific the Indian chapter, to put together a panel of regional and international speakers that will give you a unique educational experience. Now, we have had a record participation. Within only a few days of the program being published, we've had an overwhelming response with requests to join the meeting from AHPBA members across the globe. And just a quick glance at the participants here, I can see participants from the United Kingdom, from the United States, from Canada, Central America, most of the Caribbean countries, among many others. And that's not surprising considering the panel of distinguished speakers that we have today. But before starting, I want to thank the local organizing committee, the past president, Dr. Wesley Francis, for his guidance, the vice president, Dr. Ravi Maharaj, our secretary, Dr. Ara, and all members of the executive, also the panelists and all the presenters who the moderators will formally introduce. So without further delay, I welcome you to enjoy the program that we've put together. And I now hand you over to the moderator for the first session and our past president, Dr. Wesley Francis. Wesley?
Good morning, everybody, and thank you all for attending this conference. And this session is session 1 and is a pancreatic session. And our first speaker will speak on the management of borderline-resectable pancreatic cancer and the role of vascular resection. Our first speaker is Dr. Elijah Dixon, and Dr. Dixon is the past president of the AHPBA and the Canadian Association of General Surgery. Elijah attended medical school at the University of Manitoba and then residency at the University of Calgary. From there, he went on to Toronto, where he did a fellowship in hepatobiliary pancreas surgery and GI transplantation. He also attended Harvard School of Public Health and did a master's in epidemiology. Elijah returned to the University of Calgary in 2004, where he is a professor of surgery and oncology and community health sciences. His practice is focused on hepatobiliary and pancreatic surgical oncology. His research focuses in health services research, clinical trials, and improving quality of cancer surgery. I am very proud to give you today, this morning, Dr. Elijah Dixon.
Thanks very much for the invitation. I want to thank the Caribbean chapter and the local organizing committee and Professor Cawich and Professor Ara. And it's great to see my friends, Wesley, Dawn, Greg. So thanks so much for inviting me. Hopefully in the not too distant future, we'll be able to have an in-person meeting and come and visit you again. I'm going to talk about borderline resectable pancreatic cancer and vascular resection. Just trying to advance the slide. Okay, so we'll talk briefly today about definitions, what some of the issues around this topic have been and issues with definitions, what role neoadjuvant therapy plays in this area, which is an evolving area and has changed a lot over the last 10 years. And then I'll touch on vascular resections at the end and be happy to try and answer any questions. So what's the issue? Why is this a problem? And I think that this slide shows you nicely what the issue is. Pancreatic surgery's evolved immensely over the past 30 years. It's gone from an infrequent procedure that not many people were comfortable doing, that had prohibitively high perioperative morbidity and mortality rates associated with it in the 70s, and has now come down and is practiced safely by many centers across the world and across North America. And that's very different. When I was training, which I'm not that old, I'm 49. When I was training in the 90s, a typical year at the University of Calgary would maybe have 5 to 10 Whipple procedures per year in the whole city. And now it wouldn't be strange to see that in 2 or 3 weeks in Calgary. And there's lots of reasons for that, but one of the big ones is just a better understanding of the anatomy, a better understanding of surgical technique, and how to perform this operation safely. It's a difficult operation because of the proximity to multiple vital structures, especially vascular structures. And you can see here nicely the celiac axis, the superior mesenteric artery, the splenic artery, the portal vein, the superior mesenteric vein, splenic vein, common hepatic artery, and they're all within a few centimeters of each other. So one tumor can have significant effects on these different structures. And it's not really an operation that should be done by the infrequent pancreatic surgeon. It needs to be done regularly to do it well and safely. So that's why borderline resectability is an issue, because these structures come into play. What do we mean when we say borderline resectable? I think everyone has a clear understanding what's clearly resectable. So, you can see here the superior mesenteric vein and artery, nice fat playing around both. And you can appreciate that looks like it should come out and be straight away upfront resectable. We also know clearly unresectable when we see it. You can see here that you've got obliteration of the superior mesenteric vein, and you've got infiltration into the artery, and it's obvious that this is not a resectable tumor. This is, this leaves that area in between those two extremes as borderline resectable, and trying to come up with a clear definition that everyone understands what you're talking about and allows people to know that they're talking about the same sort of stage of disease and the same issues that come into play. And that's been a problem in this area. There's been lots of heterogeneity around what people mean when they say resectable or unresectable and borderline resectable. And it's required a lot of discussion and a lot of international collaboration to come up with definitions that are reasonable and that people can agree on. There's lots of variability in terms of resectability between institutions and between surgeons, and you see that when you go to and visit different places and you see what they think is resectable and what's not resectable. And I would argue that even within a single surgeon's career, what's resectable and what's not resectable changes. I think that, having been out for 15 years, what I can take out safely now is different than what I could safely take out at the beginning of my career. And I think that's probably true for most people after they've been out and gained a lot of experience in this area. There's tons of heterogeneity. If you go back and read through the literature on this topic in the last 15 years, you'll see all sorts of nomenclature and verbiage that is confusing and makes it hard to know if you're talking about oranges and oranges or apples and oranges. And so this has had to be sorted out, and there's been a lot of work done in this area to try and come up with clear definitions. The essence of why this is important, I think, is well stated by Mike Katz here from MD Anderson. They're best conceptualized as tumors that involve the mesenteric vasculature to a limited extent. Those for which resection, while possible, would likely be compromised by positive surgical margins in the absence of preoperative therapy. And I think that's critical to sort of the understanding of this issue. Questions that you need to ask yourself when you're talking about borderline resectability is, can this tumor come out safely? Will the operation be harder? Will it be more difficult? Will it require a higher level of expertise? And then what about your margins? This is part of I think how people evolve over their career. Will it come out completely? Will you be able to get an R0 resection or an R1 resection? And that takes a lot of experience to correlate what you see on the imaging with what you find at surgery. In general, what you see on the imaging understates what you find at operation. So it takes experience to appreciate that. The radiologists don't have the intraoperative correlation with what they see on imaging. The surgeons do. And I think that you get a much better idea of what you're going to encounter at surgery as your career progresses. And then if you're able to take it out, and if you're able to take it out successfully, what survival can you expect? What survival can you expect if it's got a clean margin? What survival can you expect if you have a positive margin? So these are all important questions in borderline resectability. There's been lots of evolution, lots of work on this topic, and there's been a lot of different definitions that have been used for borderline resectability. And I think that they've started to converge over the past few years, and I think have pretty reasonable definition now, and we'll come to that in a minute. In terms of the imaging, it's nice to have nomenclature that doesn't have a lot of variability in it, that we understand what it means. And if you can use the nomenclature with a simple parsimonious grading system, that really helps. And so the group at Beth Israel Deaconess in Boston, Raptopoulos, and the surgeons there have looked at the scale that they've come up with and tried to correlate it with what they find at surgery and what you see post-operatively. It's fairly simple. Grade 0 is no involvement of critical vascular structures. There's a nice fat plane or normal plane between the tumor and the vessel. Grade 1 is loss of that fat plane between the tumor and the vessel, or without smooth displacement of the vessel. So again, pretty easy to understand what they're talking about. Grade 2, flattening or slight irregularity of one side of the vessel. So you start to see a bit of deformity of the vessel, but it's only on one side. Grade 3 is tumor extending around at least 2/3 of the vessel perimeter. It alters its contour and narrows the lumen, and you sort of get that beaking or pinching that you see. And then grade 4 is occlusion and or obliteration of the vessel, and this is a nice picture of it. So I think that that's a fairly simple, straightforward grading system that most people can apply and use and agree on. There's lots of inter-observer agreement when you use that grading system. Does it correlate with what you find at surgery? And you can see here that it does. It is a nice linear relationship in terms of what's resectable based on that preoperative grading. And you can see even here with grade 0, you still have a significant percentage of unresectable patients, but it goes up, much higher as you progress along that grading scale. Well, how about the margin status? And although not quite as crystal clear, it also correlates. So as you go to the more advanced stages, you do end up with a positive margin more frequently, which is what you'd want to see from a grading system. And then survival as well, it tracks out nicely and separates, and you can see that grade 0s do the best and grade 4s do the worst, and the others fall in between. And this is important and useful. There's a whole bunch of grading systems and scales that have been used over time. These are anatomic-based systems. They're based on venous and arterial involvement. And I was involved in putting the AHPBA, SSAT, SSO consensus conference together with Nick Vothe 10 years ago now, or a little over 10 years ago. And it was an anatomic-based grading system, and it still holds today. There's been some expansion on this, but this is still gets at the heart of the matter in terms of the anatomy. So tumor abutment of the SMA does not exceed 180 degrees of the circumference of the vessel wall. Segmental tumor involvement of the hepatic artery without extension up to the celiac axis. Venous involvement of the SMV portal vein demonstrating tumor abutment with or without impingement and narrowing of the lumen, or short segment venous occlusion resulting from either tumor thrombus or encasement with suitable vessels proximal and distal that could be potentially reconstructed. And this is important because this has been identified as a group of patients that would really potentially benefit from neoadjuvant therapy. And so, if you've got one of these patients, when we put this consensus statement out, we were pretty clear. We said that patients in this category should be treated with neoadjuvant therapy, and ideally this should be in the context of a clinical trial. What's the logic for that statement? And I think that, these are the main items. You have positive margins very frequently in borderline resectable patients. So you want to see if upfront therapy, either chemotherapy or chemoradiotherapy, can improve your complete resection rate and get negative margins. There's a higher percentage of these patients that'll have occult systemic disease, and you want to try and address that if you can with upfront therapy. You want to obviously maximize overall survival. And then during the time that you treat patients with upfront therapy, some patients will progress or develop new disease, and these are patients that have aggressive cancer and would not benefit from upfront surgery. So you spare some patients futile operations. What are some of the theoretic advantages around neoadjuvant therapy? Well, the tissues are better oxygenated, so you get better delivery of the therapy. There's the potential for downstaging. You can select patients with favorable biology and avoid surgery where it would not be helpful. Enhance the chance that you're going to get a clear margin. And then the surgery may be better tolerated. The therapy, both chemotherapy and chemoradiotherapy, when you are able to remove the tumor, tend to leave you with a more fibrotic, firm pancreas that's easier to sew And so it decreases the risk of postoperative pancreatic fistula. So it does improve some of your perioperative complications. What are some of the disadvantages? Well, it requires a team environment, and it requires a multidisciplinary environment where there's good discussion around cases, requires coordination between the oncologists and the surgeons. You do need to get a tissue diagnosis before you institute the neoadjuvant therapy. You're going to have to manage chronic biliary obstruction and cholangitis and sepsis that you can get with that. So it requires a different approach to the biliary obstruction. A plastic stent is usually not going to be a good option, and you need something a little bit more durable. The full staging of the tumor is obviously not known because they don't undergo a laparotomy or laparoscopy before they start their therapy. And then there's the theoretic risk that some patients won't tolerate their neoadjuvant therapy well and then won't come to surgery. I would argue that's rare. And if they don't tolerate their neoadjuvant therapy, it's unlikely that they would have tolerated a pancreatic duodenectomy. And then finally, patients want clarity and patients want to be treated, and they don't like to wait. And I think that's not a big concern. I've heard that from many people. I think that the way that you discuss it and sell it to the patient has a lot to do with their acceptance of it. If you believe that it's going to make a positive difference and you explain that to the patient, then they'll, I think, receive it well. The Canadian system, you know, it has, we're good at looking after emergent surgical situations, urgent surgical situations. Timeliness can be an issue. And it's hard to get people into the OR in a few weeks, and usually ends up taking 4 to 8 weeks to get someone in best case scenario. So when you're having patients wait already to get into the operating room, it's much easier to convince them that the waiting is a reasonable thing if you're actively treating them. So in our system, it actually, I think, is a really good thing and is very doable. Pancreatic surgeons have really been required to be eternal optimists and the glass is half full type of surgeons, especially when you go back into the 70s and 80s and the 90s. There was really not a lot of reason to be optimism. I can remember when I was training, hearing visiting speakers come and present data on this and hearing really serious debates about whether or not we should ever be operating on anyone with pancreatic cancer because the prognosis was so dismal and the perioperative risks were so high. That's really changed a lot in the last 10 years, and we've had lots of reason to be much more optimistic. For the first time, we've actually been able to demonstrate that people get beneficial effects from systemic therapy, and that there's reason to be optimistic. And again, 15 years ago, if you said that you had seen people be downstaged with pancreatic cancer, you'd have people stand up in the audience and call you a liar. And I think all of us now have seen people downstaged regularly. So things have really changed. Fulfirinox is really the sort of standard right now, and that's what we use in Calgary. In the neoadjuvant setting for borderline or locally advanced pancreatic cancer. And, there's been a number of reviews that have looked at the data. There's not great data. Most of it is single center prospective or retrospective series, although there's starting to be some multi-center randomized trials. There's a Korean study that just came out recently. It was fairly small, but it did show beneficial effect of neoadjuvant chemoradiotherapy in terms of overall survival. And there's other trials that are accruing and are going to be reported. So there's lots of reason to be optimistic, and there's evolving data that's bearing this out. This is the Dutch group, and they looked at preoperative chemoradiotherapy and immediate surgery in patients with resectable and borderline resectable pancreatic cancer. And they've started to report the results of that trial. They've been able to show that there was a significant reduction of postoperative pancreatic fistula after preoperative chemoradiotherapy. and that there was no significant difference in respect to overall major complications, which is obviously encouraging results from that trial. This is a meta-analysis, and they looked at borderline resectable pancreatic cancer. They looked at it with an intention to treat analysis, and they were able to show that there was difference in median overall survival, 26 months versus 15 months. And they were also able to show that there was a big difference in R0 resection rate, 86% versus 66% or 67%. So differences for sure in the patients that came to surgery. Those differences are attenuated somewhat when you look at the intention to treat, but differences in either approach nonetheless. And this is just a forest plot of the median overall survival. The top is upfront surgery, and the bottom is the neoadjuvant treatment in these patients. And you can see that there's a definite trend towards improved survival in those patients that received neoadjuvant or upfront therapy. Is there anything else that we should consider in these patients other than just anatomy? And I think that there definitely is. And I think that you're seeing this borne out in publications recently and in newer definitions of borderline resectability. So tumor markers and CA19-9 levels is important. And you can see here from this pie diagram that what your CA19-9 level does while you're getting neoadjuvant treatment really predicts the resectability of the tumor. It's something that I check and I follow in all these patients, and my level of optimism and how motivated I am at the operation is high, especially when patients have a decrease in their CA19-9 and ideally normalization. And you'll see that if you stratify these patients according to whether or not it normalized and whether or not they had resection, that they break out and separate in terms of their survival, and that the resected patients that had normalization of their CA19-9 definitely do better than the resected patients that don't have normalization. And I think that if you were to look at the trajectory of their CA19-9, that would also be important. So if it's coming down, although some are not normal, but it's coming down, those patients also tend to do quite well and end up being resectable. So an important consideration in these patients. There's been new sort of discussion, and MD Anderson really was the first group to push this in terms of a new definition for borderline resectability that takes into account not just anatomy, although anatomy is obviously very important, but tries to look at biology and the performance status of the patient. I think that this is important. The biologic definition is when there are findings that raise the possibility but not certainty of extrapancreatic metastatic disease. And then the conditional definition really has to do with whether or not the patient has comorbid illnesses and or poor performance status and what their risk is for big surgery. So the anatomic issues are similar to what I've already presented previously. The biologic definition that this is a consensus conference that came out in 2017, and it was an international group of people, included Claudio Bassi, Fernando del Castillo, Matthew Katz, and Christopher Wolfgang. And you see that for the biologic definition, tumors are potentially resectable anatomically, but there's clinical findings that are suspicious for distant disease. So a CA19-9 level that's over 500 units per ml, or regional nodal metastatic disease, either diagnosed by biopsy or by CT PET. And then the conditional definition is poor performance status for patients. Those are important. I think any definition that we look at borderline resectability now needs to include those factors in it. I'm just going to finish briefly with vascular resections. I mean, this could be a whole hour talk. The sort of principles around this and the techniques and what's reasonable and what's not reasonable. I think that in terms of general principles, this is not something that even a regular pancreatic surgeon should do if they don't have experience and really extensive experience with vascular surgery, either vascular surgery or transplantation surgery, which brings with it a lot of the vascular surgery techniques. And I think that to do this safely, you really have to be comfortable with those techniques, and not just the actual surgical technique, but the principles around access, exposure, and control of these vessels, which is something that you really only get if you've operated in these areas and done these techniques frequently. So it's really for the person that is doing these operations regularly, frequently, and applying these vascular surgery techniques in a regular sort of way. If you don't have those, I think that you either need to involve someone with you that does, or you need to refer the patient to someone that does. There's no doubt that what often at initial operation looks like it's unresectable, when you apply good principles around proper exposure and control of these vascular structures, and you work at them circumferentially from easy to difficult and tackle the difficult part last, it's surprising what you're able to do, and really sort of similar to this picture. A beaver can take down a tree that's 100 years old, which you'd think wouldn't be possible, but tenacity and coming at it in the right way will allow you to do that. There's lots of publications around this, and the question that always comes up is this a biology question, or is it an anatomy and a technique question? And it was difficult, I think, to answer that when you go back and look in the 70s and the 80s, and you look at the work that Joseph Fortner and others did. The perioperative complications were so high that you really couldn't determine whether or not it was a pure anatomy technique issue or biology or a combination of both. I think that the surgical techniques have improved so much, and the facility with vascular surgery combined with pancreatic and HPB surgery, largely from the melding of transplantation and HPB oncology, has allowed us to look at this in a much more rigorous way and start to tease out what the issues are. And it's starting to look more and more like it's really not a biology issue. It's an anatomy and a technique issue. And if you can safely remove and reconstruct these vessels, then these patients can expect good outcomes. That's not to say that there's still not very significant risks associated with this. And you have to be very careful when you read these sorts of articles and interpret them, because the skill sets that are brought to bear are extensive and impressive. And this is the Toronto experience. And you know, anyone that knows Ian knows Ian McGilvery is an outstanding surgeon and has a vast experience with visceral, arterial, and venous reconstruction, and it does a high HPB and transplant practice. So those are sort of prerequisites. And if you try to apply this in other surgical environments where you don't have that skill set, it'll be very hard for you to replicate these results. So I would say that resection of both venous and arterial structures, when applied, to carefully selected cases, and you have the appropriate skill set, it can be done successfully. The level of complexity and the risks are higher with arterial cases than with venous cases. And there's still, I think, issues that need to be sorted out, especially around the arterial reconstruction and resection, and whether or not you should be doing those in the setting of pancreatic oduodenectomy, where you can get a so-called dirty fistula, which has different implications for an arterial anastomosis than a venous anastomosis. So, I think that the bottom line is that I think we're coming to a pretty clear definition of borderline resectability. It's critical that these patients are all cared for in a multidisciplinary environment, that they get preoperative therapy, and ideally preoperative therapy in a clinical trial if possible, and that you need to have expertise in vascular surgical techniques, or at least have access to that expertise when needed, to be able to safely tackle these. And I think it requires everyone to be honest about their skill set, which is, it's not a bad thing. We can't all be good at everything, and sometimes you're just in an environment where you don't get exposed to enough of these sorts of cases. So you need to involve other people and or refer some of these cases on. I want to thank you again for having me and giving me the opportunity to speak. It's a real pleasure, and it's great to see my many friends that we've developed over the years in the Caribbean. So thanks so much.
Thank you, Elijah, for an excellent talk that really demonstrate the difficulty with this topic, and you clearly simplified it, and while at the same time brought out the nuance of dealing with borderline resectable, and what's noteworthy is the whole multidisciplinary approach that you have to take with this topic, and these patients that present to us. What we'll do is that while we get questions, put them in the chat, we'll just go on to Dr. Bathe at this time, and we'll answer some of those questions in the panel. So Dr. Bathe, if you would like to share your screen at this time and start your presentation, we can do that. Thank you. Great, I think it's up.
All right.
Thank you. All right.
Thanks very much, Wes, for inviting me to present to you guys today. And I really wish that this could have been done in person, but nonetheless, it's great to meet you all virtually. And my conversation or my talk is related to management of post-pancreatic fistula, something that really affects anyone who does pilopancreatic surgery. The sequelae of this particular complication are considerable. As you know, it involves leakage of pancreatic juice and then activation of pancreatic enzymes with secondary infection. Hemorrhage is a particular problem, especially with some of those vascular reconstructions that Elijah just described, thrombosis, prolonged hospital stay, and indeed, I would say that the majority of mortalities that occur with pancreatic resections are really a result of postoperative pancreatic fistulas, directly or indirectly. A number of years ago, there was a consensus on grading severity so that we could study these entities a little bit in greater detail. And then in 2016, there was a modification of the severity grades. Specifically, those situations where amylase level was high and really there wasn't any change in postoperative management, that was really redefined as a biochemical leak, and so no longer considered a clinically relevant postoperative pancreatic fistula. A grade B implies that there's a change in postoperative management, such as drains left in place for more than 3 weeks, or drains repositioned by endoscopic or percutaneous procedures. And then a grade C implies that a postoperative pancreatic fistula is treated with reoperation or results in an ICU stay or mortality. Understanding the risk factors will hopefully help us to be able to modify the likelihood that these will come around. Unfortunately, the vast majority of the factors that are risk factors for postoperative pancreatic fistula are not modifiable. For example, patients who are particularly protected from pancreatic fistulas are patients who've had pancreatitis, who have a harder gland, and then males are particularly at risk for getting a pancreatic fistula. Blood loss is related to developing fistula, and I guess the other modifiable situation is, in a way, neoadjuvant chemotherapy. Neoadjuvant chemotherapy is really interesting in that it causes fibrosis of the gland, and we've found, as have others, that the incidence of pancreatic leaks after resection is much lower in patients who've had neoadjuvant chemotherapy. Similarly, for distal pancreatectomy, high BMI is associated with a risk of developing a fistula. Splenectomy is similarly associated with a risk, probably because the extent of the operation in general is greater. And with vascular resections, then that similarly is associated with a risk. So generally, there are host factors and there are operative factors that can contribute to the risk of a fistula. So a lot of these things aren't modifiable. What about the things that are modifiable, such as our surgical technique? And there's a whole host of factors that have been studied, and I'll go through each one of those. So the first one is whether the pancreatic anastomosis is constructed with the jejunum or with the stomach. The theoretical advantage of a pancreatic gastrostomy is that it avoids activation of the pancreatic enzymes. It's a much easier anastomosis for small ducts and soft pancreata. In fact, it's particularly in that instance where I would do a pancreatic gastrostomy. There have been a number of randomized controlled trials, and one in particular published in the Lancet Oncology described reduced risk of pancreatic fistula with a pancreatic gastrostomy. Elijah in our group has similarly studied this in a randomized controlled fashion, and we were not able to demonstrate an improved outcome with the pancreatic gastrostomy. Nonetheless, the trial has resulted, I think, in some of us utilizing that anastomosis for those soft pancreases that have a very, very small pancreatic duct. So what about anastomotic technique? There are numerous ways described in the literature in anastomosing the pancreas to the jejunum or to the stomach. And I've tried a few of these, particularly as I started my practice, because I wanted to find the best technique for me. Ultimately, there are a number of single center trials that demonstrate superiority of their particular techniques, but then when you actually put this into a randomized controlled trial, it's very difficult to replicate that superiority, because really, ultimately, what is most important is that you do whatever technique that you're most familiar with, and do it really well. And I think that that's really the ultimate message that I have there. What about stents? Well, as you know, there's two ways of putting in a stent into a pancreatic duct. One is with an external stent, and then the other is an internal stent. I have typically utilized internal stents. There are 4 trials that have demonstrated improved outcomes when an external stent is utilized. There have not been similar trials done, as far as I know, with internal stents, but I do know that the evidence demonstrates that internal stents are comparable. So generally, if in my own practice, if I have somebody with a large pancreatic duct, I'll try to avoid the stent because I think that's more physiologic. But with the smaller pancreatic ducts where I do a duct to mucosa anastomosis, my practice would be to put in a stent. Surgical adhesives have been described by numerous groups. Ultimately, there's no benefit. Mental wrapping similarly has no benefit. And what about distal pancreatic distal pancreatectomy. So multiple ways again of describing how to close a stump, either with staples or hand sewn. I'd say the majority of pancreatic surgeons now will use a stapled stump closure, but ultimately when all of this is put into a randomized control trial, there's no difference, and the pancreatic fistula rate still is 20 to 30%. So you can see, you know, that number doesn't sound like a massive number, but it's enough to really celebrate every time that somebody doesn't have a fistula, I find. Minimally invasive resections don't provide any benefit, but at the same time, they're not any worse in terms of pancreas-specific complications, and probably confer a faster recovery from surgery. So there's a number of techniques that I've described here. I would say that the major conclusion is just do the same thing as much as possible, and get as much experience to do whatever technique you do, and do it the best you can. There's been a lot of studies related to drains following pancreatic resection. The study from Sloan Kettering reported back in 2001, 179 patients who underwent various pancreatic resections, mostly Whipples. They found that pancreatic fistulas and abscesses were actually more common in the drain group, and really quite significantly more common, although the mortality was the same in both groups. That study was essentially repeated and reported in 2014 in a multi-center fashion. These were all Whipples, and indeed people who had no drains had increased grade B and C post-operative fistulas with a higher mortality rate, and so the randomized control trial was actually stopped prior to full accrual because of that outcome. The question is whether we could potentially be more selective about drainage. So for example, say you had a person who was very thin, everything went absolutely perfectly in the surgery, hardly any blood loss, no comorbidities, no vascular resection, and a nice hard pancreas. Maybe that would be the person that you would select not to put a drain into. Whereas patients with the opposite characteristics, you would most certainly want to put a drain into that person. I thought that an interesting report by Bathe et al. In 2010 demonstrated that early removal of drains had an advantage in terms of outcomes, and so generally I do try to get drains removed relatively early. So recently there was a multi-institutional trial, again reported or led by Van Buren, where patients were randomized to getting drains and no drains after a distal pancreatectomy. It was a large trial, and it ultimately demonstrated that there was really no advantage in those patients to receiving a drain. Here again is Claudio Bassi's trial of early removal of the drains, which showed that the hospitalizations were shorter in early removal of drains, which is generally, I would say, what my practice would be. Okay, what about somatostatin analogs? A number of years back, there were a few trials reported of octreotide given before a pancreatic resection, and some of the trials demonstrated an improvement in postoperative fistula rate, and others reported no improvement. Ultimately, with meta-analysis, I would say that the consensus is that octreotide does not provide an advantage. However, there's some intriguing data on pasireotide, which is a more long-acting somatostatin analog, which has demonstrated some improvement in fistula rate. I think that this needs to be studied more, and certainly looks intriguing, although it's my understanding that it's quite an expensive drug. So we've all, anyone who's done a bunch of pancreatic surgery will encounter these. It's unavoidable. How do we manage these? Most importantly, percutaneous drainage, nutritional support. These people are often, they'll have gastric dysfunction after this kind of a complication, so that they will require nutritional support. These patients have to be frequently evaluated for any septic complications. The most important thing I would say is beware of the sentinel bleed. Anyone who gets blood in their drain has to immediately be evaluated for that. So, I had one patient that I recall had a vascular reconstruction and then had a pancreatic leak, and that was exactly the situation that I'm describing. When you see that, they need to have an angiogram and immediate evaluation of that. So here's an example of a patient who had a bleed through a gastroduodenal artery. Question is whether to operate on those people right away, and if there's any delay in their surgery, then generally we'll try to treat these with embolization. This particular patient had a very short gastroduodenal artery and had a stent put into the hepatic artery, which ultimately migrated up to the liver and caused necrosis. This is, once you get a complication like this, it's really very serious. Okay, I just want to finish off by just describing a case of a spontaneous pancreatic fistula, then a postoperative pancreatic fistula following that. This is a patient who was 44 years old. She had a CT for appendicitis, and then an incidental pancreatic cyst was identified. Nothing was done related to that at the time. But then she developed recurrent episodes of pancreatitis, had an endoscopic ultrasound, no solid component was seen in the cyst. The fluid was aspirated and demonstrated inflammatory cells, necrotic cells, and no mucinous material. The fluid CEA was quite low, but the amylase was high, so it was assumed that this was a pseudocyst and she had a lap coli. Then in 2016, the cyst began to enlarge. It was thought either to be a neoplasm or a pseudocyst. MRI demonstrates some fat stranding and surrounding free fluid, so it was actually favored to be the pseudocyst following that. And the patient underwent an ERCP for investigation of a recurrent pancreatitis. They couldn't cannulate the pancreatic duct, but the pancreatic duct was abnormal. Fluid was again aspirated and was non-mucinous. Finally, in June 2019, she developed some dyspnea, had a CT for pulmonary embolus, and you can see here that she developed a very large pleural effusion as opposed to a pulmonary embolus. The pleural fluid was rich in lipase and drained, and she was provided supportive treatment. Subsequent MRI demonstrated, you can see here, the cyst, but also right next to it, a very large pleural effusion, and they speculated that there was a pancreatic pleural fistula. So we brought her to the operating room in 2019. She had a distal pancreatectomy and splenectomy. A drain was left in place at the site of the fistula. Pathology actually demonstrated a mucinous cystadenoma. Clearly this is a case where she should have had a surgery much sooner than that in retrospect. And then in November, 4 months after the surgery, she developed a new collection by her pancreatic stump, which was drained percutaneously. This was quite an unusual sort of situation. As you know, most postoperative pancreatic fistula show up within days of the surgery, whereas this one showed up 4 months after the surgery. So we tried again to insert a pancreatic duct stent in order to decompress the pancreatic duct, but this was unsuccessful. She was treated with octreotide supportive treatment, and this resolved. Ultimately, she developed this once again. It was one of those patients that you have for a full year. And she had this was managed with a transgastric stent and drainage. So this case really illustrates the multidisciplinary management of these more complicated fistula. They involve interventional radiology. They involve gastroenterology at times. And these patients require a very intensive follow-up and care. They are stressful cases to manage, particularly the more complicated ones, but unfortunately, this is part of the lay of the land of pancreatic surgery. At this time, I'll finish up, and if there are any questions, I'd be happy to entertain them.
All right. Thank you, Dr. Bathe, for an excellent talk on, again, a difficult problem that we all encounter when we are doing pancreas surgery. So we want to, again, encourage all the participants to put their questions in the chat, and we will put them to the panelists. So we want to move right into the next talk. And our next presenter is the president of Indian chapter of the AHPBA and chairman of the scientific committee of the AHPBA and treasurer of the APHPBA. He is professor of surgery and head of GI and HPB surgery at the Tata Memorial Hospital in Mumbai, India. He's also the deputy director of the Tata Memorial Hospital. I just want to introduce Shailesh Shrikhande, and he will be discussing surgery for pancreatic cancer, current standards, and future perspectives.
Brilliant. Thank you so much, Dr. Wesley. Francis, can you hear me well?
Yes, we can hear you well. We can see you.
Brilliant. So I'll start my slide share, and thank you so much for inviting me. A real pleasure and privilege on a Saturday evening to talk to all of you on a morning in the West Indies and in the Caribbean.
Yes. Yes.
I'll straight away go to my talk. I knew that Elijah, as well as the second speaker, would be covering some aspects. So I fear that there would be an element of overlap, but not much, fortunately. And I'll try to cover some of the topics which I feel would be relevant within the time that is given to me to speak on pancreatic cancer surgery. So I don't need to tell you the fact that the incidence of pancreatic cancer in my part of the world is perhaps 1/3 of what you would see in North America, Canada, as well as some other parts of the world and in Europe. But here it's about 2.7 to 4.1 per 100,000 population is what we get to see based on our registries in India. I'll try to touch upon pancreas anastomosis, the concepts that are changing as far as what is resectable and what is not resectable. What are the techniques that we have tried to employ routinely to try and improve the chances of offering an R0 resection? Because we have continued to do a lot of pancreatic work, what has been our experience with extended resections? I'll touch upon the concept of reoperative pancreatoduodenectomy. I'll touch upon ramps, as well as some of the other things that we have managed to get some data as well as some experience thanks to 2 decades of work that's focused on pancreatic cancer surgery at the Tata Memorial. Now, this kind of a picture is good for a pancreatic surgeon, bad for the patient because you have a tumor and you will do a Whipple resection. We've heard a lot of these talks which say that neoadjuvant treatment perhaps improves outcomes thanks to neoadjuvant chemotherapy or radiotherapy. Well, it's only part of the answer. The other answer is that there is intense desmoplasia and chronic pancreatitis-like changes around pancreatic cancers. I don't mean to say periampullary cancers, but pancreatic head tumors. And then you also get a fair degree of pancreatic ductal dilatation. So I would say that pancreatic cancers are bad and often difficult to resect, but they are easier to anastomose. And my focus in this picture is to show you that you have a dilated duct. So the surgeon knows that it's a difficult uncinate process mass that needs to be resected with good margins. But after the resection, the reconstruction is an easy one. This is the kind of technique that I routinely employ. Some of you have been with us from the Caribbean and you have seen us do this. We would join the pancreas in 2 layers. There are different ways of doing it, as we heard in the previous talk. But the key is to make sure that we respect all the principles of Halsted. And in this particular technique, an end-to-side duct-to-mucosa coupled with the dunking is what I have been routinely practicing for close to 2 decades. Thanks to my time in Germany with my mentor, Markus Buechler, and Helmut Fries, who are in Heidelberg and in Munich. I happen to be spending a fair amount of time with them, and we have continued a long association with them since then. Previously, we were doing a pancreaticogastrostomy. This is, of course, a single center experience of our surgical team, but you could see that we were doing a dunking pancreaticogastrostomy. And once we started doing this, myself and my colleague Parul Shukla, who is at Cornell now, but we were working together for close to 10 years at the Tata Memorial. And this is the data when we started working as a team together for 4 years. And we got a much better result as far as post-operative pancreatic fistula, bile leaks, hemorrhage, and even mortality is concerned. But admittedly, there is a selection bias here. We were a young team, we were careful, but the good thing was that we were doing the same technique in a dogmatic fashion without bringing about any change. We continued to do the same thing again and again and again. So I do believe that God is in the details, and it's important that if you want to excel in some parts of surgeries, the best thing is to try and standardize as much as you can. And you can, of course, follow those standardized steps for specific intraoperative scenarios. I did publish once, perhaps the first meta-analysis, one of the most well-cited papers in the literature. And this was to compare a PJ with a PG. And it's considered to be a landmark study. At that time, we had evaluated 16 studies with only 3 randomized controlled trials and 13 other studies. But the conclusion was you can do either a PJ or a PG. It doesn't matter. You can get equally good outcomes, was the conclusion of this meta-analysis published 13 years ago. After that, I haven't published at all. But then it came to a situation from 2010 to 2015. If you look at the literature, the kind of interest or the resurgence of interest in pancreatic anastomosis. You will get large number of meta-analysis. In that 5-year span, there were about 8 meta-analyses, some of them looking at 7 RCTs, some of them looking at 9 RCTs, and whole lot of discussion that was going on around. We got a lot of information, but it's also confusing to the reader, especially to younger surgeons. So that's when I got the opportunity to get the ISGPS together, and we came up with a position statement. Now, this is a paper which I would encourage the youngsters to look at in details, because we have looked at PG and PJ. We have looked at duct to mucosa, dunking, binding, putting stents versus no stents, internal stents versus external stents, isolated loop versus double loops of jejunum, putting drains versus not putting drains, use of octreotide and somatostatin analogs, variety of suture materials, what do you do when you do a vein anastomosis, what do you do when you do a vein and an arterial anastomosis, so on and so forth. So I think there are so many moving parts to the same story of pancreatic anastomosis and postoperative pancreatic fistula that beyond standardization, you need to be aware of all these factors in an individual patient and try and apply what is likely to work in an ideal fashion for that particular given patient. And then it finally comes down to something which I published long ago. And in fact, when I was listening to my previous speaker, I just decided to put a very old slide of mine, a decade and a half ago, where we concluded with a systematic review that all that you need is find sutures, respect the tissues well, avoid tension, make sure there is no distal obstruction, make sure there is perfect anatomical approximation as far as possible, ensure that there is a good blood supply, and all this happens in the middle of an operation. However well you do your resection, you need to pay attention to your pancreas anastomosis. So I believe it is the surgeon which is the most important prognostic factor, even in this era of evidence-based medicine. Moving on, we did hear Elijah speak about borderline resectable disease, but what is borderline resectable to me is perhaps routine resectable to someone who is highly experienced and is an expert pancreatic surgeon. Same way, what is unresectable to me can be borderline resectable or easily resectable to that same expert surgeon. So this is a moving target when it comes to what is resectable, what is borderline resectable, and what is locally advanced. Certainly, you have the anatomical criteria, you have the biochemical criteria, and you have the patient's conditional criteria. So very well shown by Matt Katz and by Chris Wolfgang and others. But what I want to show is that in this era of much better chemotherapy, excellent radiology, and increasing refinements in surgical techniques, you will convert about 70, if not 80% of borderline resectable disease into resectable disease. And you will get about 20 to 40% of locally advanced, the so-called unresectable disease, into the realm of borderline resectable disease or even resectable disease. We went on to this journey at about 2008. This was an initial series of about 12 patients. And what we realized, thanks to a very good radiologist, was that it's the length of contact, the circumferential contact, and the degree of venous deformity. This was before the 2009 AHPBA publication from Mark Calery and others, where we realized that if you have a circumferential contact and a venous deformity on an increasing scale, the chances are that the patient is going to require a vein resection. We also, in the meanwhile, developed a dedicated pathology team, and this is a series of more than 160 pancreatic resections, where we have looked not only at periampullary tumors, but also pancreatic cancer. And what we have seen is that 57% of our patients of pancreatic cancer were positive or R1 based on the Royal College of Pathologists of England or the Leeds protocol, where we gross the specimens in a particular way and we report the pathology in a particular fashion. And obviously the most commonest margins which were positive was the posterior pancreatic margin, as well as the margin to the vasculature, i.e. the superior mesenteric artery. So this happens not only in pancreatic cancer, even 7% of our periampullary tumors, apparently everything looks clean and nice on the operation table, but the pathologist will afterwards tell you that it's been an R1 resection. This is not R2, mind you, but an R1 resection. Keeping this in mind, I think the best thing that one can do is to try and do as clean a surgical resection as possible. And that's where I started taking a fair bit of interest in the superior mesenteric first approach late in 2008 and early in 2009. We were doing a conventional right medial approach, but then we decided to compare the various approaches when it comes to superior mesenteric artery first approach. So we compared the infracolic approach, which you can see with the yellow dot over here, with the conventional right medial approach. When you approach the superior mesenteric artery in the supracolic compartment, move the vein aside and go to the artery. So this is one work that we have done in 2012. But the other relevant work which is going to help us and which is already helping us to improve our outcomes is to do the mesopancreas approach. This complicated diagram on the right side, I think the most important thing is those 3 black lines. LV1 is to the right of the vein and a very conventional approach to go beyond the uncinate process into the mesopancreas and do a complete resection of the lymphovascular tissue posterior to the mesenteric vessels. But if you have a vein involvement, you need to have an LV2 approach and go to the left of the vein and to the right of the artery, and then you will be able to get a more complete clearance. On the other hand, if you have the most extreme type of borderline resectable disease, you will need to go to LV3, where you go to the subadventitial plane into the artery, leave the artery aside, and then you are able to take it out. This is something like the divestment technique in pancreatic cancer surgery, which is gaining in prominence now. So in this picture, as Elijah said, we can go on for an hour for vascular resections, but the highlight of this picture is only one. You get an SMA first with a complete clearance, as the white arrow will show you. You get complete control of the splenic vein, portal vein, the posterior right hepatic artery, the common hepatic artery, the pancreatic neck is divided, and we've got the SMV also looped up. So go from the easy to the more difficult part, and then finally you have the whole specimen which is hanging only on the vein. You resect the vein, use a 5-O proline, and you will be done with this after a good growth factor. You will be done with the type 3 anastomosis in about 12 or 13 minutes. This is something that we would routinely do, something which we were not doing routinely a decade ago. So again, go from the easy to the more difficult, and you will be in a much better situation. Do we have data to justify what we are doing? Perhaps we have. Of course, the quality of data is not very high, but again, we have looked at what has SMA first done in the last 8 years or in the last 6 years since we first published about SMA first. And what we see is a tendency towards higher R0 rates. You also see a tendency towards higher overall survival. I'm not saying this is only because of surgery. I'm saying this is because of chemotherapy, radiotherapy, multimodal treatment, but also high quality surgery. So I think the surgeon continues to play a dominant role in an aggressive disease, which is a systemic cancer like pancreatic cancer. Thanks to this, we have continued to do a little bit more. I need to update this data. My apologies that I haven't updated this data since the last 3 years. In this picture, you see that we have divided the splenic artery and divided the common hepatic artery and swung the splenic artery to rejoin and reperfuse the left and the right hepatic arteries. So here was a case of borderline resectable disease involving only the common hepatic artery. The vein was fine, the pancreas was fine, everything was R0, but the artery was involved. Something like this, we would make it inoperable more than 10 years ago, no more. In these cases, we would go ahead and offer them various forms of vein, arterial, as well as multi-organ resections. Is this worth it? It seems to be worth it because the morbidity is acceptable. Yes, the mortality creeps up a little bit, but if you're going to get 4 people out of 10 who are going to be alive for 3 years with good quality surgery coupled with good chemotherapy, with a good quality of life, in selected patients of pancreatic cancer, you can do extended pancreatectomies and multivisceral resections as well. Moving on, this is my younger colleague, Dr. Manish Bhandare, for whom I do give a lot of credit for trying to push something like this. This is locally advanced, unresectable pancreatic cancer. Celiac and proximal hepatic and splenic arteries are encased. Patient has received FOLFIRINOX, the full spectrum, in a neoadjuvant fashion. CA19-9 has come down. Patient's performance status is 1 and excellent status. And what we have finally done is that we have safeguarded the gastroduodenal artery, which was supplying the liver. We were prepared for a graft from the aorta to the common hepatic artery if there was a problem of blood supply to the liver. And we are able to get an R0 resection by doing a celiac axis resection and doing a subtotal pancreatectomy for a tumor, which again is unresectable to begin with, but in good responders, you would be able to cut here and go right here and do a complete resection. A 66-year-old gentleman with a background of doctors in the family came with locally advanced disease. And our answer again a few years ago was, we can't operate on you. We'll give you chemotherapy. He came back with chemotherapy and he said, why are you not operating on us? Pancreatic cancer is best treated by surgery. I said, yes, but this is locally advanced. We'll give you radiotherapy. He said, okay. He went ahead and got radiotherapy. After that, he came back again and he was in excellent condition at the age of 66. And he said, you go ahead with resection. That's the pancreatic remnant. We've done a vein resection. There was a big gastrocolic right gastroepiploic vein available. We don't have to preserve it, but we did preserve it for the venous drainage of the stomach. The bile duct was non-dilated. Tumor was going right down to the celiac. We could do a divestment technique and take it out of the common hepatic artery. We divided the tortuous splenic vein, and then we could go and do the so-called triangle operation. This is the superior mesenteric artery. This is the celiac axis. All the tissue has been cleared, and this patient did well for close to 3 years with multimodal treatment, including surgery. So clearly the disease has remained the same and nothing about it has actually changed. It is we who change as we learn what was formerly imperceptible. Moving on, we did see this particular slide, not this slide, but something similar from Dr. Dixon about the work done by Paul Gregg and the others in Toronto. This is similar. This is from Heidelberg. I won't support it very strongly as of now because you can see with a lot of work, you finally reach a 5-year survival of 12%. So I'm not sure that arterial resections are definitely on. But yes, with much better chemotherapy in the last 5 years, we've reached a stage where we can, in occasional patients, not only do a shelling out or a divestment, but we can even do a few arterial resections like SMA as well as hepatic arteries. Moving on, looking at subtotal or left pancreatectomies, I think RAMPS is here to stay, very well described by Steve Strasberg long ago. But this is also something which can be very well standardized and more easily amenable to the minimal invasive approach. So you can certainly do RAMPS with a very good laparoscopic surgeon, or if you are more comfortable with the robot and have the possibility of robotic surgery, RAMPS is better treated, I would say, increasingly as compared to an open approach in pancreatic body and tail tumors. I had the opportunity to work during the Sao Paulo meeting where we had a consensus conference at the AHPBA in 2016. And we were a large group of stakeholders, both open as well as laparoscopic surgeons, as well as all others who were involved in the management of pancreatic cancer. Again, this will give you details about why minimal invasive distal pancreatectomy has a very good future and it is here to stay. I'm not saying this during the course of this lecture about Whipple resection as yet because we are still struggling to get there. But as far as distal panc is concerned, we are very much there. There are some other issues which are important. We have a dedicated ERAS nurse and an ERAS program where the first author over here is our chief GI anesthetist. I'm one of the co-PIs. And what we have observed is that if we have a dedicated and focused compliance, which is getting to more than 80%, you will have much better outcomes when it comes to treating patients with pancreatic cancer, or for that matter of fact, even all other major GI or abdominal cancer surgeries. As I come towards the end of my lecture, this is what I want to share with you. This is our own data. I was the Warren Fellow in Heidelberg in 2006. And since then, we've gradually experienced growth as pancreatic surgeons individually, as well as growth as a dedicated team which is specialized in doing pancreatic surgery. I must say that I am happy as well as surprised, but we continued operating throughout the COVID pandemic as a specialized oncology center. So even in 2020, I've just got the data yesterday that we have done 163 Whipple resections with another 27 non-Whipple resections to have 190 resections done in the year 2020. We've published some of this data. Overall, our mortality is less than 3%. The morbidity is about 30%. It clearly means that despite increasing complexity, increasing volumes, and expanded surgical team, it is easily possible to deliver high quality results based on a foundation of standardization and then documentation over a period of time. So this slide is something which I have recently made. I did get the chance to learn in Germany a decade and a half ago. And then today we have about 35 surgeons across the country, across the length and breadth of India, not just in tier 1, but tier 2 and tier 3 cities, who are able to do the same kind of pancreatic work that we do. I regularly keep on getting messages from young surgeons from all over the country and even abroad about the fact that they are able to do high quality pancreatic resections. I think this is important for a low middle income country like India, that we try to spread the message of excellence and try to improve the quality of surgery by mentoring young surgeons. The other area where I'm trying to pay attention now is, of course, trying to look at centralization, and we have documented data across the Indian subcontinent. You can see how things change if you are doing less than 10 cases, if you are doing 10 to 25 cases, and if you are doing anything more than 25 or 26 cases a year. Things obviously improve if you're going to be doing at least 2 Whipple resections a month. You will be much better when it comes to your short-term as well as long-term outcomes. So clearly, mastering pancreatic surgery needs patience and time. And Jennifer Seng has shown it to us that you need about 60 cases before you can get there. Because of this experience, we also have a number of patients who get referred to us where they have been opened and deemed to be unresectable. We have re-evaluated them with previous scans as well as the new scans, and we have been able to offer them a resection. And in the vast majority of resections, it was suspected or perceived vascular involvement. It was not actual vascular involvement. That's the importance where young surgeons should know. You should study your radiology on your own and be very comfortable with the anatomy in the region, and you will be able to do a much better job than having to open, do a bypass, close, or inform the patient that it can't be done. That's not the case in this series of close to 50 patients. Learning is the same. Now we have got minimal access, and if you have a learning curve for open surgery, you're also going to get a learning curve for robotic as well as laparoscopic surgery. Again, a very good paper from a world authority, and you can see that you need at least 80 cases before you can reduce your operating time, and you need 20 cases to reduce your blood loss and conversion. So you can't ignore the learning that goes into developing pancreatic cancer surgery. What about the future? Here you see that this is a cancer which has got perhaps large number of genetic alterations, and we have known this thanks to modern molecular biology in the last 27 years or so. And this is an example where you can see what molecular biology can do. This was during the time when I was in Germany, but this has been not published. But you can see that you have wild type KRAS in mice, and you inject cerulin and you get acute pancreatitis. But by day 14, the pancreatic architecture becomes normal. But if you have KRAS, you will see that the changes after cerulin do not change, and within 14 days, you get development of pancreatic ductal adenocarcinoma. So clearly there is a link between inflammation and carcinogenesis, and we need to understand this more and more. And thanks to that, we are in a position where we are able to have genetically engineered mutant mice and develop organoids also from patients. And this is something which we are trying to develop at the Tata Memorial in conjunction both with Princess Margaret as well as from Boston, where we'll be able to work on patient-derived organoids and try to individualize treatment in this era of precision medicine, as well as in the era where we understand that PDAC develops through a series of pan-ins. There is something like an adenoma carcinoma sequence. We understand more with IPMN that we are going to be able to treat pancreatic cancer better in the next 10 years. But it's a complex cancer where there is a lot of epigenetic changes that are constantly happening. So we are some way off, but we need to look at biomarkers which are beyond CA19-9. And the reason is a neoplastic cell in the pancreas takes more than 10 years to generate distant metastatic disease. So we do have a large window for early detection of pancreatic cancer. And this is a recent paper and a very interesting paper looking at precision oncology in surgery. I'm not going to go into the details, but you can look at the 3 survival curves. If you have S100, A2, and A4 negative, you're going to have people living much longer. On the other hand, if both of them are positive, the survival tends to come down. I'm not saying this is only going to dictate the way we treat, but this is going to be complementary as we go ahead in the management of pancreatic cancer. Look at this case again. We can subtype pancreatic cancer into stable, scattered, unstable, locally rearranged. You have a patient with surgery, adjuvant gemcitabine, recurrence in 10 months, and then you are able to identify with subtyping what you can do, and they get platinum therapy, and patients are still alive for 30 and 35 months thereafter. You can also see the kind of changes that you will see in radiology. So this is something which is going to come up more and more as we go ahead, and we will have to integrate not just surgery, chemotherapy, and radiotherapy. We'll also have to integrate modern molecular biology so that we can have a balanced approach while treating pancreatic ductal adenocarcinoma. With this, I think for constraints of time, because we have a panel discussion ahead, I would like to stop. But the work that I presented is thanks to a fantastic team that I lead here. And this is the gastrointestinal disease management group, as well as the group of surgeons who are working in pancreatic surgery, gastric surgery, hepatobiliary surgery, colorectal surgery, as well as other specialists who are all dedicated to the art and science of GI and HPB oncology. Thank you once again. I wish I could have been there in person rather than virtually, but I'm very glad to have had this opportunity to talk to all of you.
Thank you so much, Professor Shrikhande. We're going to now go to Dr. Kimon Bonadie, who will take us into the panel discussion. Kimon, you can introduce Dr. Major and the panel. Thank you. And again, if there are any questions, please put them in the chat for the speakers.
Hey, good morning and greetings from the Caribbean. Our next speaker will be having a case discussion, and he's Dr. Don Major. He is a graduate of the University of the West Indies, He did his undergraduate training in Trinidad, the Trinidad campus, and he was one of the first Bahamian residents to graduate from the Bahamian training program in surgery. He then went on to Baker Center, Cancer Center in Calgary, Alberta, where he completed his fellowship training in surgical oncology and AHPB. He is currently a consultant surgical oncologist, hepatobiliary surgeon at the Princess Margaret Hospital in the Bahamas. And he will be having a short case discussion on the challenges in the Caribbean in operating on patients with pancreatic cancer.
Good morning. Can everybody hear me?
Yes, we can hear you, Dr. Major.
Thank you. Thank you, Dr. Bonadie, for those kind words. And I'd like to thank the organization for granting me this opportunity to present here today on basically our challenges that we face in the Caribbean with respect to the Whipples procedure. Can everybody see my screen?
Yes.
Okay. And again, good morning, and my name is Dr. Major. And we're going to talk a bit about, or have a little panel discussion this morning with respect to the management challenges in the Caribbean. And we've had quite a bit of information this morning with respect to borderline-resectable pancreas cancer, post-op pancreatic fistula, current and future perspectives in the management of pancreatic cancer and its surgery. This morning, we're going to kind of change it up a bit, and we're going to ask each of our panelists a few questions about a case that we encountered some months back. Presently, I have nothing to disclose, and this is our beautiful hospital that we operate out of here in the Bahamas. It's the Princess Margaret Hospital. So just getting right into it, we have a 60-year-old female who was known to be hypertensive as well as diabetic. And she was relatively well up until 3 weeks prior to her presentation. At that time, we saw for those 3 weeks, she was complaining of yellowing of her eyes as well as itching of her skin. She also complained of some pale stools, dark urine, as well as some associated anorexia with some weight loss, but no fever, chills, nausea, vomiting, or any change in bowel habits. She's never had symptomatology like this prior, and she's never experienced any previous bouts of abdominal pain or admissions to hospital for any similar abdominal pains. She did have a myomectomy in the past, and she's not known to be allergic to any foods or medication. When we saw her, she was obviously icteric, but acyanotic and afebrile. Her vital signs at the time showed that they were all within normal parameters with a pulse rate of 94, blood pressure mildly elevated, at 156 and 96, but nothing that really stands out to you. And when we did examine her, she did have a vague, non-tender mass in the epigastrium. Going in, these were her lab investigations. She did have a CBC that showed that the white count and hemoglobin were all normal. Her MAC7 were all within normal ranges. And when we looked at her liver function testing, we noted that her total bili was 14.4, and the remainder of her liver enzymes were also mildly elevated. She did also have a CA19 at 9 at that time, which was less than 2. She went on to have an ultrasound that showed no sonographic evidence of cholelithiasis, but she did have a dilated CVD. Now, this morning I realized that my scan was not coming up on the presentation, so I just asked you guys to bear with me a second as I switch over to the image. So this is our preoperative image. This is a CT scan with IV oral contrast. And as we're going down, we can see the dilated ducts within the liver, the dilated common bile duct that becomes obliterated just at the head of the pancreas, as well as she had a mildly prominent pancreatic duct. There was no evidence of any extrahepatic disease. any extra or metastatic disease, I'm sorry. And the CT report did confirm that there was a ill-defined mass in the pancreatic head, about 2.3 by 1.3 centimeters. There was also, as we can see, dilated ducts, as well as a mildly prominent pancreatic duct.
Dr. Major, the scan isn't showing up. Can you see if you can get it up, or
Okay.
is that?
Yeah, 1 second. I will work on that. Let's get back to where we were. Let's close this down. Where is that now? Ah. Oh boy. Okay.
Dr. Major, if you could open the file beforehand, and then I'll share that particular window itself. There you go.
You can see that?
We were seeing it.
You were seeing it? Okay. You see it now? Are you still seeing it?
Yes.
Okay. Yeah, sorry about that. So yeah, she did have a CT scan with IV and oral contrast, showing the dilated intrahepatic ducts as well as extrahepatic ducts, going down to the pancreas head where it becomes obliterated, as well as a mildly prominent pancreatic duct. There was no evidence of any metastatic disease. And the CT report did say that there was an ill-defined mass within the head of the pancreas, 2.3 by 1.3 centimeters, mildly dilated pancreatic duct, as well as dilated biliary radicals. So I would like to kind of take a break here and ask Dr. Shrikhande, are you happy with this information that you have here? And if not, what would be your next step in the management of this patient? And if you could give us a little explanation as to why.
Can you hear me now?
Yes, sir.
Sure. So I think what I've seen is a triphasic CT scan. I could see the biliary anatomy fairly okay. There's clearly a dilated pancreatic duct. I could not see any vascular involvement per se. I could not see any problems around the SMA. I could not study the common hepatic artery as well in great details, but that's fine. I suppose the common hepatic artery is normal as far as its variants are concerned. I did not find any ascites. I did not find any problems with the liver. However, I could not see any CT scan of the thorax or of the lower abdomen. So I think when I look at a disease which has a high propensity for metastatic disease, as a part of a workup, we would do a CT thorax as well and continue the CT scan down to the pelvis as well. But otherwise, on the looks of it, this looks resectable tumor in the pancreatic head, periampullary region, and would benefit from a Whipple resection.
Thank you. Dr. Dixon, would you go ahead and order an EUS for this patient, or you just as well go to the operating room with this bit of information that we have?
Is this for me?
Dr. Dixon, if he's there.
Hi, can you guys hear me?
Yes.
Yeah. So I agree with everything Shailesh said, and I would not do an EUS, and I would take this patient to the operating room after a discussion around what we think is going on, the relative likelihood that this is a cancer, what the possibilities are in terms of pathology, and the risks and benefits of the surgery. But I would proceed with surgery.
Okay, so that is what we did. We decided to take this lady to the operating room, but we got a bit of information on the day of the operation when she was in the theater. Hadn't been put to sleep as yet. But when we were checking her labs, we noted that her total bilirubin had fell from 14 to 3.6, and her liver numbers were starting to come down. And this was probably about, I would say, about 2 weeks after a presentation to us in the office, when we decided to take her to, or when we had an opportunity to take her to the operating room. I would pause here, and I would go on to ask Dr. Kluger, what would be your thoughts now?
Okay, can you hear me?
Yes.
Okay, so, I mean, I think one of the points, I did not hear that CA 19.9 was done earlier on. Of course, you could end up with a false positive if the bilirubin was that elevated, even in a benign setting. Still, with the appearance of a mass, even with the drop in bilirubin, no autoimmune history, this age group, not a clear understanding of why she would have. It's pretty rare for an acute pancreatitis to cause such an elevation in bilirubin. Even within the limitations of the Caribbean, I would still consider continuing on with this therapy and not being thrown off by a lab. Because we have to remember, although there are clear indications for doing EUS and FNA, you definitely can get a false negative, especially when you're starting to get optimistic about a patient not having cancer and you're trying to convince yourself that the patient does have cancer. That the patient does not have cancer. When we're dealing with pancreatic cancer, we don't have time to sit and wait for tests and tests and tests like we can with less aggressive tumors. And I find a lot of providers, before they get to the surgeon, will try to do everything they can to convince the patient and reassure the patient that they do not have pancreatic cancer, when in fact they do. And then they show up in our office 6 months later with metastatic disease because they looked for a few little optimistic signs and delayed. So I would still go to the operating room. I would still see if a frozen section was available in the operating room to kind of confirm. But I would proceed with surgery despite this rapid decline in CA 19.9. Rapid decline in bilirubin, excuse me.
Yes, thank you, Dr. Kluger. That's exactly what we did. We decided that, we should still go ahead with the operation. And at the operation, we did an open Whipple procedure where we did a pancreatic jejunostomy, HJ, and a GJ. We left a Jackson Pratt drain behind the pancreatic jejunostomy. We did not leave an NG tube. Surgery was actually pretty uneventful. Dr. Dixon, Dr. Bathe. You gave a presentation earlier with respect to drains and postoperative pancreatic fistula. In a lady such as this, where the procedure went relatively straightforward, she had a nice duct that we can do a ductal anastomosis to. Would you have left any drains or even an NG tube in a case like this? Dr. Bathe?
Yeah, so ordinarily I wouldn't leave an NG tube unless there were some complications encountered during the surgery. I would leave a single drain. I leave it right behind the hepatojejunostomy, extending in towards the pancreaticojejunostomy. And, she still does have a risk factor. She's diabetic, as I recall. So, I don't see the downside of putting the drain in, to be honest.
Would there be anybody that wouldn't leave a drain in a situation such as this? Okay. So moving on, the postoperative period, day one post-op, when we saw in the ICU, because we generally place our patients in the ICU after a Whipple or major liver resection. And day one, we noted that she was somnolent or lethargic. And we looked at all the vital signs. They were all within normal parameters. The urine output was great. We did her blood investigations. White count was mildly elevated at 13,000, but everything else looked relatively normal with respect to her blood investigations. The only thing that we could think of was that she was getting a morphine infusion overnight. So maybe we had overdosed her with some opioids, and this had since discontinued, and we would review her later on the following day. On post-operative day 2 now, she continued to be lethargic, continued to be somnolent, even after about 24 hours of the opioids being discontinued. She wouldn't complain of any pain despite not getting any pain medications at all. Her vitals remained within normal limits. Total bilirubin came down now to 2.5. Her liver enzymes went up a bit mildly, and again, like I said, her white count was 13.5. Because we weren't entirely sure what was happening at this point in time, we decided to run off a bit of cardiac enzymes to determine whether or not this may be some form of cardiac MI or myocardial infarction, which were all normal. So we decided that we'd give it a bit more time and see how she does the following day. Now, you can go to this lady's bedside and she would have her eyes closed the entire time, but if you call her name, she would respond to you, she would open her eyes, but she would just go right back to sleep. They actually had her out of bed on post-operative day 2, but she was in the chair mostly just asleep the entire time. Post-operative day 3 now, again, still remaining lethargic, somnolent. Here's where we decided, okay, let's try and ramp up our investigations as to what exactly is happening with this lady. So we went on to get her a CT brain. Again, that came back unremarkable. We're also wondering now, we've had our first few cases of COVID-19. You know, this isn't going the standard way in which we expect to see a Whipple in the post-operative period. So could this be COVID-19? We ended up going on and getting a swab for her, and sure enough, the COVID test was negative. LFTs remained to trend down, and she kind of stayed this similar course over the next few days. And again, lab works were fine, vitals were good. She was making adequate urine, so there wasn't any signs of any ongoing sepsis or anything that may be contributing to this. So we reached the post-operative day 5. She's still doing the same. And we've done a gamut of investigations and yet to figure out exactly what it is that's causing this lady's somnolence. So here it was that we thought, okay, could this possibly be a dreaded pancreatic leak? Now, I put the question to you, Professor Shrikhande. Is there a role at this point in time for a CT of the abdomen, even though during the entire time her abdominal findings were relatively unremarkable? A JP drain at this time was putting out about 30 mils of serosanguinous fluid. But yeah, well, would you consider doing a CT of the abdomen to assess for a leak, or would there be any other investigation that you'd want to determine what's happening with lethargy?
So I think there are 2-3 thoughts when I look at post-operative day 2 and 3. Are you sure your electrolytes were all okay as far as sodium and potassium and chlorides were concerned? They were all bang normal?
Yes, they were all within the normal ranges.
And how was the CRP? Was the CRP done on post-op day 3 or 4 by any chance, or there was no CRP done?
No, there was no CRP done at that time.
All right. And do we have any information about serum lipase or amylase?
The serum, and this is one of the challenges that we experienced here in the Bahamas, we did send off for serum lipase levels. We sent it off on day 3, but we didn't necessarily get it back until about day 7 or 8. Okay. And at that time, the result came back that it was actually within the normal limits.
All right. And was the patient moving bowels by post-operative day 3 or 4? Was she She may be lethargic, but was she taking by mouth? How was she in terms of her pulse, her blood pressure? I know the urine was fine. She was breathing fine. The CT brain was fine. The leukocyte count is okay. But how was she eating and was she moving bowels?
It all remained the same. You know, she was mostly sleeping throughout the days and nights. You can arouse her easily, or you can call her name and she would open her eyes to you and she would respond a bit. If you would ask her a question, if she's having any pain, she would tell you no. But then after a while, you just notice her just drifting back off into the somnolent state.
And was a drain amylase done on day 3?
Yes, but like again, the drain lipase, we didn't have the amylase. And the drain lipase, like I said, the result didn't come back until about day 7, which is normal.
Okay, so there are 2 ways of looking at this. This lady is hemodynamically stable. She's got an improving leukocyte count. Her liver functions are coming down well. Clinically, her abdomen is soft. It was an uneventful Whipple resection, and I had seen the dilated pancreatic duct pre-operatively. So I suppose your experienced surgeon has done a great pancreatic jejunectomy or a satisfactory pancreatic jejunectomy. If she's otherwise okay, and if you have ruled out things like drug interactions and electrolyte imbalances, I would not push for a CT scan abdomen on post-op day 5. I could clearly still manage her clinically, knowing fully well that sooner or later I will have a low threshold for doing a CT scan of the abdomen, which is more of a precautionary scan because your drain amylase is okay. And yes, I would perhaps do a procalcitonin or a CRP before, despite the decrease in leukocyte count. So it's a long answer, but it's relevant because you need to look at the whole patient as a whole rather than just would I do a CT or not. You know, that's different.
And I totally agree with that. But again, us being a bit nervous as into why she's doing this.
If you are nervous, do a CT scan. Okay, you want me to tell you that? Do a CT scan. Okay.
We did end up doing one, yes.
Yeah, I see that.
Now let me see how I can get back to share that. So this will be the last time I have to share. Okay. Can we see this?
No.
No?
No, not yet.
You have to share screen.
Share screen. Where's the screen? Okay. All right, let's try that one more time. Do we see that?
Yeah, we see
okay.
it.
So yeah, this is a CT scan on day 5, showing a little subcutaneous edema, as well as there was a bit of free fluid within the pelvis, but nothing too remarkable. There's our drain going in, and again, like we thought, no real evidence of any major anastomotic disruption or anastomotic leak. But once we got up to the chest, we did note that she had some bilateral effusions, as well as there was some evidence of collapse consolidation within the bases. So at this time now, we decided that she doesn't have an obvious pancreatic issue. Her CT brain was normal. I forgot to say we even did a CT pulmonary embolus, again, which was unremarkable. It just showed that she had the effusion as well as some atelectic changes. And she kind of did this way for the next 10 to 14 days, never really waking up. But then we were able to get back her pathology. Oh, there you go. Yeah. And the pathology came back as this. There was no evidence of any malignancy. It was all chronic pancreatitis with a heterotrophic pancreatic tissue of the duodenal wall. So this was to our surprise that we had this diagnosis in this lady. Again, we were wondering, kind of looking back, you know, whether or not an EUS would have benefited. But again, this is what we kind of brought up at the beginning of the conversation. And knowing that there are false negatives associated with the EUS. Professor, okay, you have a question for me?
More than a question, I think I have a comment. I don't think you have done anything wrong. You have a patient with obstructive jaundice. You have a patient with a double duct sign. And what you have discovered is chronic pancreatitis, which can be focal or involving the head. And a Whipple resection can very well be the treatment for chronic pancreatitis. So nothing wrong. That's point number one. Point number two, worldwide, data where you have gone ahead for doing a Whipple resection with a solid mass based on radiology, you will have anywhere between 5 to 12% cases post-operatively turning out to be having a diagnosis which is more benign or something which would kind of make you concerned. We published our own data of 446 Whipple resections in Langenbach's Archives of Surgery in 2016, and we have had a 6.5% negative rate. 29 patients did not have a malignancy. Out of 29, 17 of them had chronic pancreatitis, and the remaining 12 had a variety of rare situations, which are a surprise, despite they getting CT, plus minus MR, plus minus EUS, plus minus EUS FNA as well. So despite doing everything, we could have yet landed up in this situation is what I want to reassure you. And I think even the other surgeons are very likely to agree with what I say, but I want to hear their thoughts.
Yes,
Michael Kluger again. So I definitely agree with my esteemed colleague. Sometimes we don't necessarily in our mind think we did the right operation, but we did the right operation. And we then concern ourselves more when we have these unstable, unexpected outcomes. And then we question ourselves more about whether we did the right thing. But who knows, when the patient came in with acute on chronic pancreatitis potentially and cholangitis in 2 more months because we didn't intervene, and then rapidly succumbed and died from necrotizing pancreatitis in the setting of cholangitis in a very weird presentation, we would have thought to ourselves, should I have operated 3 months earlier? The questions on my mind now were more about potentially what her performance status was when she came in. Was her performance status really being hyped up by her family and by herself because she wanted to get potentially to the operating room, but maybe there had been a rapid decline in her performance status over the preceding weeks to months, so that then after she got the extra stress of the operation, her body just kind of potentially really fatigued and gave out in the recovery period, a reversible situation, but maybe better explains why she's not as, why all systems are go, but she just doesn't have that oomph to move forward at the current time because her body's now dealing with a secondary stress from a major operation.
Okay, thank you for that. And here ends the end of my presentation. I would like to thank all the panelists for participating and for providing us with their insight on these challenging issues that we sometimes face. Thank you.
Don, just one question. I know everything was fine. Could anyone explain she being so lethargic and drowsy?
We didn't find an explanation for it. I'm sorry.
Okay. Okay.
All right. Thank you.
Thank you.
Okay.
Okay, morning everyone. This brings us to our second half of our session. First speaker will be Professor Sean Cleary. He's a hepatobiliary surgeon and surgical oncologist at the Mayo Clinic. He is Canadian. His clinical interests are that of surgical treatment of pancreatic, hepatic, and biliary malignancies, with specific focus on minimally invasive approaches for these cancers, for research interest in epidemiology and pancreatic and hepatocellular cancers. So Dr. Cleary, welcome, and you can begin your presentation on minimally invasive approaches, the Mayo Clinic experience for liver resections.
Okay, great. Thank you very much, Greg. And let me just see if I can yeah, sorry. Just trying to get my screen to share. Sorry, they switched computers on us now. So there we go. All right. Let's just see if I can. All right, so thank you very much, everybody, for the really kind invitation. It's a real honor. It's great to see so many friends, and it's a tremendous session you've got put together. So it's a real honor to be involved. Again, the only bitterness to my presentation is that many of you are in a much better, warmer place than I am right now. And this is actually a picture taken yesterday of, so just to let you know, it's pretty cold outside and probably much colder than where many of you are. But I'll try and get past that bitterness to say that, and try and get onto the matter of hand, which is obviously, I was asked to talk about minimally invasive liver surgery. And obviously I think we can all see from sort of a wide view, the particular advantages to minimally invasive surgery, as it's been applied to many types of surgery. We obviously know that there are, if we could do surgeries through smaller incisions, we can reduce our postoperative pain. We can reduce the amount of peritoneal trauma, and I'll allude to that later in terms of some of the benefits, particularly for cirrhotic patients. It also makes what is a very stressful operation, both for the surgeon and the patient, at least less stressful for the patient, possibly more stressful for the surgeon. And so I always say that I'm trading the patient's stress for my stress in the operating room. And all of those things with a less physiologic stress and less trauma and less pain leads to expedited recovery and shorter length of stay. This field has evolved, and you can see that these are some of the evolving publications that really, this is a relatively new field in the fact that we only really started to see people publishing their experience in the early 2000s, so about 14 or 15 years ago. And again, some of the early experiences were interesting to watch because the vast majority of them were very small resections. So about almost half of the resections were less than one segment, so wedge resections. But we also saw some concerning trends that a number of these procedures were being performed for benign disease when that didn't really reflect what our open experience was. As we sort of evolved, and again, this is about 10 years later, we started to see more experience being published. And again, we started to see a normalization of that benign to malignant balance that sort of reflected our open experience. The issue, however, though, was that really this was predominantly minor resections that were being published. And again, when people think about trying to tackle minimally invasive liver surgery, they try and picture themselves doing a trisectionectomy or a right hepatectomy, which is really not what the vast majority of surgeons are doing. The evidence has certainly evolved. As we can see, those publications sort of have amassed, and we've killed a lot of trees trying to compare outcomes of laparoscopic versus open. And so really the summary is that for minor resections, the data is fairly well established and fairly consistent, that when you look at a variety of post-operative complication outcomes and complications, laparoscopic procedures do tend to do better over open procedures in terms of reduced risk of complications, reduced blood loss because of the effect of pneumoperitoneum and reducing bleeding during surgery. That translates into a reduced use of transfusions and reduced length of stay. Now, when you move up to major resections, so we're talking about lobectomy or more, you can see, first of all, one is that there's a lot less literature available just because I think there's a lot less experience with them. But the benefits are not as pronounced. So we start to get that balance between the stress of the surgery and the magnitude of the incision in terms of the percentage of the morbidity that's associated with the incision starting to even out, and that we do have some trends towards lower complications, definitely less blood loss and shorter length of stay, but certainly what we can see is longer operative time in some of those cases, particularly since many people are early in their experience. When I got started in laparoscopic liver surgery, one of the ways in which I think it really helped me propel was some of the benefits in trying to resect patients with cirrhosis, because one is that was a group of patients that none of my colleagues were particularly excited about operating on. And we started to see, particularly the hepatologists could see, the significant benefits in patients with cirrhosis when they could have a laparoscopic compared to an open resection. So we mentioned that it's less physiologic stress, and we can measure that in a variety of ways, like fancy tests like IL-6 and tumor necrosis factor and cortisol. But certainly what we found was that there were more moderate fluid shifts. So the patients didn't require as much fluid in the postoperative period, leading to less fluid retention and edema. It also, I think, had a significant benefit in maintaining some of the abdominal wall vascular collaterals that these patients are kind of dependent upon for their maintaining their homeostasis. So a big right subcostal incision, I think I underappreciated how much that disrupts some of their collateral flow in patients with mild portal hypertension. So what we saw really is that these patients did so much better with a laparoscopic resection that we had lower rates of postoperative ascites, encephalopathy, and liver failure, so much so to the point that the hepatologist would only refer patients for surgery if it could be done laparoscopically, and certainly in patients who are Child's B or have portal hypertension. So we talked about the postoperative outcomes, but if we can improve our postoperative outcomes, but not offer the same oncologic outcomes, we're really not making significant progress. And I think we're starting to see more data in this regard in the longer term outcomes in terms, especially in HCC, where data out of Asia has been quite prolific. So here you can see again a series out of Hong Kong, where we saw, again, the outcomes that we would expect with lower blood loss, transfusions, and shorter length of stay, and an acceptable perioperative mortality, but actually equivalent or maybe even better oncologic outcomes in the longer term. And this has kind of been shown multiple times in multiple sets. I just kind of list these as a couple of examples in terms of comparing the oncologic outcomes of minimally invasive surgery, because this was obviously something that was a concern when minimally invasive surgery has been applied to cancer operations, whether that be in colon or other solid organ malignancies such as renal cell. And I think we're still having debates in rectal cancer as to whether minimally invasive surgery offers equivalent oncologic outcomes. I keep listing that bottom paper there from France because it talks about laparoscopic liver surgery in the elderly, where the elderly in France are apparently defined as older than 55. So as I get closer to that number, I'll probably take this paper off my list of things that I refer to. But one of the things that I think that people, when they start to embark on this, get a little bit intimidated by is the idea that they all of a sudden have to be doing a vast majority of their cases laparoscopically. And again, I think it's important to understand that this is still something that's evolving in terms of its use and its experience. So this is a summary of the National French Surgical Database. And again, I think France is one of the Western countries that has led laparoscopic liver surgery. And you can see how really laparoscopic liver surgery was only a small, very small proportion of their liver surgery throughout the country. You can see that in a nation leading the world in laparoscopic liver surgery, it only really was accounting for up to 7% of liver surgery about 5 or 6 years ago. So it's not going to be something that's going to be applicable in people's practice to every one of their liver resections. And I think we need to be very selective, and it leads to the importance of patient selection and case selection. But again, the French were able to show that this was in colorectal cancer. Again, the long-term outcomes were very equivalent, so that we weren't sort of taking shortcuts for shorter incisions and compromising people's oncologic outcomes. One of the questions is how to do this how to introduce this in your hospital, particularly when resources are a limitation. And while I'm in the United States right now, I practiced for a long time and started my program in Canada, where we had a very similar healthcare system. And this was one of the emails that I got after one of my first laparoscopic liver surgeries. And I'm sure we've all gotten emails from our administrators saying how expensive these cases are because of the extra equipment needed. And you can see how this person who was thankful that I blocked their name out copied most of our surgical leadership. Again, just complaining about some of the costs of laparoscopic liver surgery. And again, the next case, a couple months later, they truly weren't successful in dissuading me. So they sent more emails to more people complaining about the costs of these procedures. So we actually started to look in our hospital at the costs of laparoscopic liver surgery. And one of the things that I think hospital administrators forget is the actual cost of open surgery. So we forget that to sterilize a retractor and to sterilize instruments carries a cost, but our administrators only see the costs of staplers and other disposable equipment that we use in laparoscopic surgery. They start to have seizures when they think about all the things that we're going to use in these techniques. So one of the things I think we're very happy to show, and this again used hospital data. So we looked at the costs in Canada from the time the patient entered the hospital, walked through the door to the moment they left. And we did everything, including counting the number of pain pills they had and how many jellos they took in, and really looked at all costs. And so this was a comparison of laparoscopic and open liver surgery, again, early in our experience, but we showed that actually the costs in the operating room were equivalent and maybe slightly favored laparoscopic surgery, that our administrators forgot the costs of open surgery. But where we saw significant savings was on the ward, in terms of these patients requiring less nursing care, less pain management, less pain medication, and less physiotherapy, and that we were able to show that actually laparoscopic liver surgery saved about $1,500 from the beginning of the patient's hospital stay to the end. So this became very sort of valuable information for us to get rid of those emails that we were constantly getting from the administration. Again, we showed this in distal pancreatectomy as well. Again, the operating room costs in the operating room were not that dissimilar, but where you save significant money was on the ward, in terms of the less care required to look after these patients and shorter length of stay. They wanted to talk a little bit about what we're doing now at Mayo Clinic. So this is, I just pulled together our data from the past year, 2020. You can see that we did 109 laparoscopic liver resections, and we did about 450 open resections. And you can see that the vast majority of our procedures were colorectal liver metastasis, because that's what our practice does. But also hepatocellular carcinoma is still a common indicator, mainly because you're dealing with sort of solitary lesions that are more amenable to laparoscopic surgery. We've certainly done a lot more work around gallbladder cancer and being a little bit more comfortable with the portal lymphadenectomy that we need to do for this procedure. But also note that a number, like almost more than half of our procedures are relatively small. So 1 or 2 segment resections, again, are the patients we think benefit the most, knowing that about 10% of our patients' laparoscopic procedures are major hepatectomies. And again, this is sort of after a number of years. One of the things that we had in our practice was trying to figure out how to use a hand assist as part of our armamentarium. And what we were concerned with was some of the data coming out that hand assist was actually had similar postoperative outcomes to open surgery and therefore offered very little benefit. So we had one of our fellows who the Calgary folks know well, Mike Dreger, put together our experience over about 13 months. And again, looked at our pure laparoscopic and hand assist procedures compared to our open procedures. And again, what we are fortunate to see here is that we saw the certain benefits, particularly when we matched the equivalent operations between laparoscopic and open, that we saw that our operative time was a little bit shorter, our blood loss was less, and our return of bowel function and length of stay were certainly shorter. But what we saw was that hand assist was somewhere in the middle, that it was certainly had longer length of stay and longer outcomes than pure laparoscopic, but certainly better than open. And what that told us is that probably if we can do a procedure, if we can't do a procedure laparoscopically, but we could use a hand port or a hand assist, or alternatively, instead of converting a procedure from open to hand assist, laparoscopic to hand assist, there may be still some benefit for the patient. And again, this just kind of shows this nicely in that our length of stay as well. Better with pure laparoscopic. Hand assist still offers some benefit, so that if you feel like you can, hand assist is a way that you want to go to help build your experience, it certainly is very, very reasonable. So just a quick summary of the evidence is that we know that there's decreased length of stay and blood loss with laparoscopic procedures. The OR time is the same or shorter, and we can offer equivalent oncologic outcomes. And the long-term outcomes appear to be similar with reduced perioperative morbidity. But this has been a difficult thing to kind of learn. And as we say, we think of the adoption of laparoscopic cholecystectomy and fundoplication is happening very, very quickly. But we're certainly seeing a slower adoption with laparoscopic and minimally invasive surgery for solid organ surgery, including when we look here, comparing this for nephrectomy and for benign cancer indications. And so it really is kind of something that a number of people are struggling with in terms of how to introduce this into their practice. And one of the hardest things about this is the learning curve. And so a number of sort of very prominent surgeons have done very well to publish their learning data about their learning curve that I think helps us understand the process of trying to introduce this into your practice. This was Daniel Cherki's data. He's a surgeon from Paris who's one of the leading international laparoscopic liver surgeons. And one of the things I took out of this paper was that laparoscopic liver surgery, even in his hands, still was a minority of his practice, that it got up to about 20% of his practice, but really he was still doing the vast majority of his procedures open. And so that kind of normalized things for me a little bit, that I didn't need to be tackling everything laparoscopically. It also showed that there are fits and starts, so that you can gain some confidence, but then you will have conversions or have complications, and we need to be sort of aware of those things as we go through our learning curve. It would seem that the learning curve for most minor liver resections is probably about 60 cases, and maybe even longer for major cases. So again, that's a difficult learning curve for many people, depending on their clinical volume. One of the things that I think is exceptionally important is to have a good team. So this is my team here at Mayo Clinic. I'm fortunate enough to have the same team in the operating room most days that I operate, and that these people kind of help me, and that they know how we do things laparoscopically and can react in situations. And so they alleviate a lot of the stress and strain of a laparoscopic procedure. If you're dealing with a new OR staff that have never done these procedures before, it can be very challenging, and it adds to your surgical stress. So the other challenge is also with the evolution of liver surgery, that when I've finished training, we did a lot of lobectomy and a lot of wedge resections, and now we're moving to more complex anatomic resections and parenchymal sparing procedures. So this certainly adds to the complexity of trying to introduce laparoscopic liver surgery into your practice. We'll just do a couple of short videos, really just to kind of show some of the things that we can accomplish. This is sort of a portal dissection for a right hepatectomy, and this is where I sort of tell my team that I need to have my nitro patch put on, because this is still, I find, quite a stressful part of the procedure, but you can see there that what we try and do, and again, trying to develop our learning curve, is really trying to replicate the open operation into the laparoscopic environment. So we don't do the operation differently than we do open. We just do it through smaller incisions. And here you can see sort of us taking the right hepatic artery and dividing it, and then moving on to the portal vein. Again, just trying to replicate what I would do open, and try and do it through smaller incisions. One of the things that certainly is difficult, as we know, in open and laparoscopic liver surgery, is really the trying to dissect through the parenchyma. In Toronto, we used a lot of what we call the water jet, and there's a laparoscopic application for the water jet. That's a little bit of a challenge, particularly when the water ends up on your laparoscopic camera, but there are sort of, this is, I think, allowed us to be a little bit more confident coming through the liver, just because we don't have to use just a pure energy device and find things blindly. You can see here, this is the V5 branch, where if I tried to take this with an energy device, I probably would have ended up losing a lot of blood. There's also the CUSA, which other people are familiar with. So again, this is a device that they've adapted for laparoscopic use. And again, if that's something you're used to using open, there's a laparoscopic adjustment for that. And again, same thing that will allow you to sort of be a little bit more confident coming through the liver with tools that you're used to using, and replicate a technique that you're used to doing open. Finally, obviously, the sort of cirrhotics that I think do very well. This is obviously relatively mild cirrhosis. And again, you can still sort of work through those patients, and these ones do exceptionally well. And what these liver dissection devices do allow you to do is sort of work through the liver parenchyma and identify those structures that will sort of get you into trouble if you try just to sort of cauterize them or burn them. So I want to thank you all for the honor of this invitation. It's great to see everybody, and I hope to see everybody in person at some point in time. But certainly, I think it's an interesting topic of minimally invasive liver surgery. It's something we're all kind of struggling with, and how to use it in our practice and how to gain enough experience. It certainly is a field that's still evolving. It's an issue in terms of the learning curve, but I think we're becoming better at teaching it. Some of the, there are now some very well developed mentorship programs that that I'm also involved in. So I'm happy to, if anyone wants to reach out, I can get them in contact and get them into a mentorship program if they're interested in doing this. And again, look forward to meeting everybody in person, and happy to take questions at any time. Thank you again for the honor of the invitation, and have a great day.
Thank you very much, Dr. Cleary, for a nice presentation. Definitely in the Caribbean, this cost, we definitely need to focus on our costs, the usage, and it definitely, especially if we're starting out with like left lateral segmentectomy and stuff, we can weigh the disposable costs are indeed high, but your info on the actual cost savings in the recovery period are very important, where we can put through to our administrations. Just one question from Dawn quickly. What degree scope do you use for your right-sided laparoscopic liver resections, and anything special? I guess the energy devices are what would be surgeon specific, but any particular special equipments that would require for this?
Yeah, great question. Thanks, Greg. It's in terms of the scope, I use a standard 30-degree scope. There's we have a 45-degree scope that I'll occasionally use when I'm mobilizing the right lobe of the liver, just because I need that extra angle. But for the most part, I try and keep it pretty simple. From a special equipment, other than a standard energy device, I try and again keep it pretty simple. I still Canadian, so I still keep costs in mind. The only special thing I think would be that lap CUSA or the lap water jet, which I use for more complicated resections. I don't use it for a left lateral or a simple wedge, but certainly something a little bit more complicated, I'm tending to use that. And those plug into your regular water jet or CUSA generators, so you don't need to buy a whole new generator.
All right, great. Thanks a lot. Thanks again, Dr. Cleary, for your presentation today. All right. So our next speaker, again, if you have any further questions to the audience, you can just put them in a group. You can address them. We'll try to address them later. But our next speaker is Professor Mahaesh Goel. He's the Chief of Hepatobiliary Surgery at Tata Memorial in Mumbai. Area of specialization includes liver tumors, primary and metastatic, with a case series of more than 800 liver resections he have done. Gallbladder cancer, again, also more than 1,500 surgeries for gallbladder cancers, and also has an interest in retroperitoneal tumors. Publications-wise, he has published more than 100 PubMed Index publications and book chapters. Today, Professor Goel would be addressing the topic of colorectal liver metastases, its management. Professor Goel, thank you for coming.
Thank you, Greg. It's an honor for me to be part of this first HPB Oncology Conference of the Caribbean. It's a first for me to address this audience. I would especially like to thank Dr. Ara, who invited me and who has spent a fruitful but difficult 1 year during COVID times with us. So coming to the topic of colorectal liver mets. So this is a very old slide, but old flow chart, but it kind of summarizes the metastatic burden of colorectal cancers. And you will know that almost 30 to 35% are liver limited metastasis, but of those, very few are initially resectable. So the whole treatment is factored towards achieving more and more resectability in colorectal liver cancers. So why did at the turn of this century, colorectal cancers with liver metastasis was considered was still ominous and with distal survival outcomes. However, advancement in liver resections in the last 2 decades have dramatically improved the long-term survival of the colorectal liver metastasis, with you can see a 5-year survival of more than 58%. So why did this survival improve? It improved as our understanding of CRLM evolved, and we recognize that it's a biologically distinct oligometastatic state with less aggressive tumor biology, and the focus shifted to achieving R0 resection at both intrahepatic and even extrahepatic sites, which was aided by aggressive surgical approach and coupled with better therapeutic drugs. And with time, the definition of resectability changed and became more and more practical. So we were looking at oncological and technical criteria for resectability, where oncological criteria meant achieving R0 resection after ruling out progression of disease or gross distant metastasis, and technical criteria meant preserving adequate amount of liver for safe resections. So if we really look at colorectal liver metastasis, there are 4 distinct types of colorectal liver metastasis. One are obviously clearly resectable. Others are potentially resectable but may require careful planning. Third are lesions which are unresectable at presentation but can potentially be converted to resection after, say, chemotherapy or any local therapy. And 4 are obviously unresectable with or without extrahepatic disease, and which are very unlikely to convert even with effective systemic therapy. So if we want to really discuss colorectal, it's a vast topic, but I will try to touch upon all these points which we should be knowing about in management or surgical management of colorectal liver metastasis. I'm not going into the medical or chemotherapy part of the management, which in itself can form a theme for a full conference. So first would be synchronous colorectal liver mets. So view of synchronous, which accounts for almost 20 to 30% of patients at presentation. The view of synchronous colorectal met is shaped by 2 concepts. One is that it is a special subgroup of tumor with distinct biology and prognosis, and that the simultaneous management of colorectal liver mets can have considerable benefits. However, there is a debatable surgical management in terms of the operative approach which should be used for these synchronous mets, the order of resection, as well as timing of chemotherapy. And this requires a complex sequencing. So of managing patient at 2 different sites. One is a primary site and another is the liver. So for example, if you look at rectal tumors, so you will, now the standard of care is neoadjuvant radiation for rectal tumors followed by surgery. So the sequencing has to be maintained in such a way that you are treating both the primary as well as the metastatic liver lesions. The three approaches, as you can see, is a classical approach, simultaneous approach, or a liver first approach. So classical approach is the staged approach where you resect a primary colon if it is a colonic cancer. But if it is a rectal cancer, you need to give neoadjuvant chemoradiation, which is then followed by resection of the primary and followed by continuation of chemotherapy. And even only after chemotherapy is given, then the liver is addressed. The rationale for doing this is that the primary should be managed first because it is a source of complication and future metastasis. This also provides opportunity to recover from primary surgery to start chemotherapy early. And then the whole concept of natural selection, where the less favorable tumors or disease will progress despite prime surgery and chemotherapy and will preclude curative resection. Advantage is that you avoid morbidity of two major surgeries and early introduction of systemic chemotherapy before liver resection. Only disadvantage is that the disease can progress or liver met can progress while awaiting its turn to get addressed for surgery. Another approach is a synchronous resection where both simultaneous liver and colonic resections are done. It is now considered to be safe and effective. Advantage is that you avoid second laparotomy, there is shorter hospitalization and less financial burden because both the surgeries are done in single hospitalization. Studies have shown that there is no change in morbidity and mortality with shorter treatment time, and you initiate adjuvant treatment for the colorectal tumor early because the whole tumor burden is addressed. However, if you plan to do a major hepatectomy with a simultaneous resection of the primary, this definitely increases morbidity for the patient. And also, as I said before, this may not be feasible for rectal tumor where you really need to give neoadjuvant chemo and radiation as a standard of care. Finally, the third approach for synchronous tumors is a liver first approach. It is generally given for asymptomatic small primary with a heavy burden of metastatic disease. Now, the rationale is based on the fact that the curability of liver metastasis and not the primary determines the prognosis in this group of patients. And also that the liver met can progress during treatment of primary, which can preclude curative treatment, which can be offered at that point of time. And neoadjuvant chemotherapy allows initial control, downsizing of liver mets, and delivery of radiation to the primary during the period when chemotherapy is being given to downsize the liver mets. And of course, you also avoid unnecessary colorectal surgery for an asymptomatic primary. Only disadvantage is that primary can progress at that time while we are addressing the liver and can become symptomatic. So which approach is better? Till now, there is no RCT to compare, RCT which says superiority of one above the another. Multiple meta-analysis, systematic reviews have been published in last few years, which has looked at all the three approaches. And finally, they have said that there are equivalent outcomes from different surgical strategies. Patient and tumor-related factors may favor one approach over the another. But the findings till now support continued use of all the three pathways until we have better evidence to guide selection and better selection criteria for each of these approach. So next thing is about perioperative chemotherapy. The practice-changing trial of Nordlinger published in 2010 really changed the way we looked at colorectal liver metastasis. It showed a 3-year progression-free survival of 9% and in the initial phase. However, there was no difference in long-term survival at the end of 8 years. So till now, the evidence is unclear whether to use neoadjuvant chemotherapy or adjuvant chemotherapy for treatment this is for resectable colorectal liver mets. However, they concluded after the long-term result that surgery without chemotherapy should now become the standard of care for resectable colorectal liver metastasis. So whenever you have a resectable colorectal liver metastasis, it should be operated and probably adjuvant chemotherapy can be given. So looking at the benefits of pre-hepatectomy or neoadjuvant chemotherapy, the whole idea was that another conclusion drawn from the same trial was that since it improved progression-free survival, which is a surrogate marker for overall survival, it should be used as a reference point for treatment of resectable metastasis. But more important than that, it should be used for downstaging or downsizing liver metastasis, what we call as conversion chemotherapy, so as to increase the R0 resection rate. The main hypothesis of using neoadjuvant chemotherapy for liver mets is that it allows in vivo testing of chemotherapeutic efficacy of the drug, because we will definitely need to use the drugs after even the surgery for improving survival. It also identifies occult intra or extrahepatic metastasis with early exposure to systemic therapy. And in addition, it also allows for improved patient selection for resection of colorectal liver mets following the principles of natural selection. However, chemotherapy does have its own share of problems. So if you really look at the number of cycles which can be given before we do the liver resection, there is an exponential increase in morbidity and mortality once you cross 5 to 6 cycles of chemotherapy. Main drugs like irinotecan can lead to chemotherapy-associated steatohepatitis, where the liver will almost behave like a cirrhotic liver. And if you're using oxaliplatin, you will have sinusoidal dilatation and blue liver, which can have a very catastrophic effect during surgical resection with uncontrolled bleeding. In addition, there is always a risk of disease progression on chemotherapy, as well as a risk of dropouts of patients on chemotherapy. Another issue is about disappearing liver mets on chemotherapy. Benoit et al. Definitely showed that even if we have liver metastasis before chemotherapy almost, and they disappear on chemotherapy when the patient was explored or the surgical specimen were excised, 83% of the liver mets were not cured and they were actually still there. So there are two issues about disappearing liver mets or vanishing met. Is that first thing, we have to be 100% sure that they are true DLMs, where two imaging are a must to diagnose. And if you are really looking at management, there are two schools of thought. One is about aggressive surgery, where blind hepatotomies can be done to take out the tumor which was originally at that site. However, studies have shown that there is no improved advantage in overall survival in this group of patients, though it did show that resection recurrence-free survival did improve. However, our policy is to observe and treat these liver mets as and when they appear on their own merit, instead of doing a blind surgery or blind hepatomies for patients with the disappearing liver mets. But important is to clearly define that these are really two vanishing liver mets. So other thing is about metachronous lesion, or if you really look at liver lesions which appear later on in the course of the disease. So there is no improved overall survival, disease-free survival for receiving pre-operative chemotherapy. So whenever feasible, adjuvant therapy is upfront resection should be done for metachronous liver lesion, and patients should receive adjuvant chemotherapy after that. So what about resection margin in colorectal liver mets? In the era of modern chemotherapy, negative margin still remains an important determinant of survival and should be the primary goal of surgical therapy. Impact of positive margin is more pronounced in patients with suboptimal response to systemic therapy. So how much is a safe resection margin? Propensity score matched approach free margin was sufficient to achieve 33% 5-year overall disease-free, and extra margin which did not add any disease-free survival advantage to these group of patients. So a 1 millimeter cancer-free resection margin should now be considered as the standard of care. If we look at recurrence and redo hepatectomies, early recurrence, of course, after first primary surgery for liver resection has poor outcome compared with late resection. And if we really look at re-resection, so patients who had late resection, even after re-resection, did much better than patients who had early recurrence, both in terms of having recurrence in the liver as well as in extrahepatic liver sites. and which are the patient which you should be resecting. So if we look at this systemic review also showed that the diamond shifts towards the left, indicating that there is a definite advantage of revision or redo hepatectomy if you have a isolated colorectal liver metastasis. So the criteria for longer survival or advantage of having a redo hepatectomy, a longer disease-free interval, a solitary liver met at second hepatectomy, unilobar liver met at second hepatectomy. The size of liver met should be not more than 5 centimeter, no extrahepatic disease, and you are able to achieve a R0 resection. So what should be should we be resecting extrahepatic disease? That is another question which props up in colorectal liver metastasis. Dr. Saklani will of course talk about peritoneal metastasis, but this systematic review showed a definite advantage of resection at extrahepatic sites, with lung being the best example other than the liver, where you can achieve a 3-year overall survival of 59% and 5-year of 33%, followed by lymph nodes and peritoneum. This again review article published in HPB showed that the colorectal liver mets with lung extrahepatic disease, a single site disease, has a 5-year survival of close to 60%, a 3-year survival close to 60%, and 5-year survival of close to 40%, which drops when you have peritoneal disease and further drops when you have lymph nodal disease. But having said that, there is still a definite advantage of resecting these if compared to when you are not resecting any of these and just giving chemotherapy. So the challenge is in defining which patients are the best candidate for such an approach, where you can do both extrahepatic and liver resection. Young fit patient with limited and favorable hepatic metastasis, a single site of resectable extrahepatic disease, and responsiveness or stable tumor on systemic chemotherapy. Chemotherapy before surgery is important in such group of patients, but it helps to guide patient selection and to rule out aggressive disease based on progression. Location of extrahepatic disease also matters. Patients with pulmonary metastasis are much more favorable than nodal or peritoneal metastasis. Of course, initially bilobar metastasis, number of mets were also considered to be a relative contraindication, but now studies have shown that even the number of metastases are no longer a contraindication. You can do extended hepatectomies, you can do 2-stage hepatectomies, you can do combined hepatic resection and ablation, and you can still achieve a favorable 5-year survival of not less than 20% in even these group of patients. Aggressive surgery, the next step is ALPS, which is associating liver partition with portovenous ligation stage hepatectomy. It was supposed to be a novel approach suited for colorectal liver metastasis, but the benefit has to be weighed against risk of increased morbidity due to infection. Randomized control trial looking at ALPS versus 2-stage hepatectomy did show a benefit or survival advantage in colorectal liver mets, but the same study, which is the LIGRO study, they concluded that both ALPS and 2-stage hepatectomy have high rate of complications and postoperative morbid mortality, indicating that less invasive methods should be explored as far as treatment of colorectal liver mets are concerned. What about liver transplantation? Because colorectal liver met patients are young and suffer from what has now become a chronic disease with long-term survivors, liver transplant is emerging as a potential additional intervention, not only with regards to improvement in quality of life, but also long-term outcomes, with 5-year survival figures being comparable to those achieved for other indication for liver transplant. However, there still remains skepticism and reluctance, mainly because of oncological safety of the procedure in terms of the disease coming back, also as well as due to immunosuppression and development of secondary or second malignancies. Also, more important than that is the fear of wasting valuable resource, that is the organ liver, which would otherwise be available to the liver transplant patient community at large for other indications. Until now, there are no clearly defined criteria and indication for liver transplant. So as of now, liver transplant is not advocated, but once indications are clearly defined, we can envision a future in which liver transplantation may hold a clear position in the armamentarium of modalities to treat patients with colorectal liver metastasis. Over years, interventional treatment modalities have gained popularity in the treatment of small tumors. RFA has therefore been postulated and propagated as an effective treatment alternative to surgery for colorectal liver mets less than 3 centimeters. However, if we look at available evidence for resectable lesions, RFA has shown lower rate of complication, but also lower survival and high rate of recurrence as compared to surgical resections. And the lower local recurrence rate as well as 5-year recurrence-free survival was much less in patients of RFA compared to patients who underwent hepatic resection. Till now, we do not have any level 1 evidence for local regional treatment like RFA for resectable small colorectal liver mets, but 2 ongoing RCTs, that is the collision trial and HELARC trial, may probably give that answer. But till then, resection still remains the gold standard for colorectal liver mets and should not be replaced by ablation at present. Ablation only should be used as an adjunct to resection and as a single treatment option when resection is not safely possible. However, when you have unresectable disease, the initial study, the only RCT published on that, which is the ERTC clock trial, showed RFA plus systemic therapy resulted in significant longer progression-free survival, and the long-term result also showed an improvement in overall survival. So, systematic review also showed or postulate that there is a long-term disease control and lower complication rate when we combine local treatment like RFA along with systemic chemotherapy versus giving systemic chemotherapy alone. So there is a definite role for local control for unresectable disease in such a situation. Finally, MIS, which most of us talked, Dr. Sean Cleary has already spoken about MIS. The randomized control trial, Oslo Comet trial, addressed that issue. And after almost 3 decades, laparoscopic resection for CRLM has shown to produce superior perioperative and short-term results compared to open surgery. However, there is still paucity of data regarding major resections, resection of metastasis in difficult locations, and for resection for recurrent metastasis. Even robotic surgery is showing promising result, but there is still a long way to go before it is really accepted as a standard of care for colorectal liver metastasis. So as of now, MIS or laparoscopic liver resection should be done only in high-value centers in presence of experts and should not be routinely recommended. So let us just now quickly look at few guidelines to manage colorectal liver metastasis before going on to final conclusion. So these are the EcoSlim guidelines which were published for 5 years back, which kind of summarize the 4 different clinical scenarios. So if you have asymptomatic colorectal disease and resectable synchronous MET, chemotherapy first, followed by surgery or stage resection. Now, in this, there is no strong evidence for chemotherapy first, and you can actually go ahead and do a synchronous resection in such a situation upfront also. Another is asymptomatic colorectal primary with non-resectable MET. In such a situation, you give chemotherapy first with the aim to make liver resectable, followed by surgery, which would be a liver first approach. If you have symptomatic MET primary with resectable synchronous MET, so you can resect primary followed by chemotherapy and then surgery for liver met, or this may also be a situation you can do a synchronous resection if the liver met does not entail a very major liver resection. Finally, if you have a symptomatic primary and non-resectable met, only if you have a tumor which is perforated or totally occlusive, you do a resection for primary followed by chemotherapy and then surgery if tumor shrinkages are achieved, or if it's a bleeding tumor, you can just start chemotherapy and it will stop the bleeding, and then you assess which to operate depending on the tumor reduction. A much more simplified version is this table, which looks at status of primary colorectal. If it is asymptomatic, you have to look at liver met, whether it is resectable or unresectable. Asymptomatic primary unresectable liver met, systemic chemotherapy, and then you recess. If asymptomatic primary resectable liver met, this is where the controversy is, whether you give chemo first or surgery first. Both are acceptable as of now. However, if you have a symptomatic primary and a resectable liver met, again, either you resect primary or you can go surgery first also. However, if you have an unresectable liver met, then you have to treat a symptomatic primary before you can actually address unresectable liver met by chemotherapy. So that can be done either by palliative resection or stent or radiotherapy. So finally, where are we heading actually? After talking about aggressive surgery for colorectal liver mets, whose philosophy dominated the last decade of surgery, I feel that this decade is going to be an era of precision medicine, where treatment needs to be personalized by the multidisciplinary team by adapting its response to each new recurrence. Please remember, though we have not talked about chemotherapy, today chemotherapy has assumed a definite central role in the management of colorectal cancer. So even colorectal cancer follows the basic biphasic pattern characteristic of all oncological surgery. So we have witnessed a phase of escalation and therapeutic aggressiveness, where we have gone ahead and done aggressive resection, two-stage hepatectomies, ALPs, even liver resection, and we have really pushed the boundaries of surgery. However, I think we are moving now to a phase of de-escalation, which is aimed at decreasing the morbidity while preserving the gains of survival, by better understanding the impact and biology of the metastatic process, and with increasing role of parenchyma preserving resections. So this is our modest data of Tata Hospital, where we have put in MDT. Our data is not as big as what you will be seeing probably in your Western countries. So we have treated almost 350-400 cases of colorectal liver metastasis, 200 by surgery and by other modalities, with fairly good results. So finally, to conclude, if you really look at the take-home message, the management of liver met is highly complex owing to multiple treatment modalities. Adding to this complexity is the marked heterogeneity of the patient group and the overlap between different scenarios. Maximizing resection for colorectal liver metastasis using all available techniques still remains the key objective and provides the best chance of long-term survival. For unresectable patient, optimal systemic and local regional chemotherapeutic, biologic and radiotherapeutic treatments definitely improve survival and may convert initially unresectable disease to operability. So to conclude, effective management results from careful and informed discussion from an experienced multidisciplinary team, which involves radiology, both diagnostic and interventional, medical oncology, liver surgeon, colorectal surgeon, and pathology, that is histopathology. But it is incumbent on such MDTDs to remain up to date in this fast evolving field. Thank you for your kind attention.
All right. Thank you very much, Professor Goel. We appreciate your presentation. Very timely. Definitely in the Caribbean, most islands don't have like a colon cancer screening program as in a national-wide screening. So we definitely will be encountering patients with colorectal liver metastases. I know you're running a bit over time. Just one quick question from Ali in the group here. How would you manage a case with colorectal liver mets and peritoneal mets as well? Would you do it in terms of a stage approach at the same time of cytoreductive surgery and HPB, or how will you go about? I know Professor Saklani is talking about HPB next, but your thoughts on that quickly?
So again, so if it's a peritoneal disease, we would probably like to control the peritoneal disease or extrahepatic disease only if I'm pretty sure that the extrahepatic disease can be controlled either by HPB or chemotherapy, and we see response to control in peritoneal disease, which is extrahepatic disease. Does it make sense to try and control or treat the colorectal liver metastasis? If it is a large met, then anyway it cannot be treated. For small mets, we have to first see the response to chemotherapy and treatment of the peritoneal disease before we will go back to treat the liver met.
Great, thank you very much. All right, so we're running a little behind time, but I'll just introduce our next speaker, Ravi. He's well known to us in the Caribbean, surgical oncologist and hepatobiliary surgeon in Trinidad. He's going to be the presenter for the panel discussion session, and then we'll probably try to get back in Professor Saklani's presentation after on the HPB.
Okay, thank you very much, Greg. I hope that you all can hear me. Greg, are you able to?
Yeah, we could hear
Thank
you.
for that introduction, and good morning, good afternoon, good evening to all. And thanks to the panel members for taking time to support the Caribbean HPB Association. I'll just share my screen here. Right, so this is the Caribbean here. We are known for many things. We are known for the beaches. We are known for our culture. We are known for a university, a top-class university. We were known for cricket, but that is not this discussion to have for now. And I am right here in the island of Trinidad. And what we will be discussing for today is colorectal liver mets. I chose that because colorectal liver mets is by far the most common hepatic malignancy that we see here in the Caribbean. So in the interest of time, I'll get straight to it. I know it's quite late now in India, so I'll get straight to the discussion. So it's case one. It's two cases. This is case one. 65-year-old male, very fit, ECOG 1, just had mild symptoms of anemia. Hemoglobin was just about 9.1, so it's not too bad in terms of anemia. But of course, he went on to have a colonoscopy and showed a lesion in the hepatic flexure. Biopsy, poorly differentiated adenocarcinoma. His CEA was actually quite high, over 200. So went on to do a CT scan, chest, abdomen, and pelvis. Of course, there was a lesion in the hepatic flexure of the colon, but no local invasion. Everything is nice and resectable. And as expected, with that high level of the CEA, the patient did have colorectal liver mets. Quite a large one at 5.5 centimeters in segment 8, as you could see here, and then about 3 more around segment 5 and 6, as you could see right here at the pointer. All are resectable. The chest was clear of any mets. So just as an illustration to help us to conceptualize where things are, this is where the colon primary is. 3 in segment 5 and 6, and this large one here, 5.5 in segment 8. So what we will want to discuss in this particular case, this is case 1 of 2, 4 things in terms of the workup, whether we're going to have chemo first or surgery first, synchronous versus stage, and if stage classic or the reverse, meaning the liver first. And this is a nice way to follow the talk that Professor Goel did. So the first thing, in terms of the workup now, this patient already had a colonoscopy and biopsy and a CT scan. Do we need anything more? Professor Shukla, are you on? So in terms of the panel, we have Professor Shukla, Professor Goel, Patka, and Professor Cleary as well. Professor Shukla, if you're on, what do you think? Would it be okay if I start off with you? And Greg, maybe we could ask the audience what are their thoughts. Does this patient need a PET scan, an MRI, a liver biopsy? Professor Shukla is my mentor in India. He now works in New York Presbyterian, and he's the chief of colorectal surgery there.
Hi, Ravi. Good morning, everybody. Good evening. Great to connect back with my previous alma mater at Tata Hospital. So, as always, a good question, Ravi. I think if you have a good biopsy from the hepatic primary cancer, we are pretty confident that these lesions in the liver are also from the same source. And since this has all appeared synchronously, I don't think there would be much role in trying to biopsy these liver lesions at this stage. However, if there was any concern on the imaging that these lesions may not be metastatic lesions, or if these had appeared subsequently, if you have a patient in whom you have treated the primary and then patients appear back on their surveillance scans with liver lesions, more often than not, our oncologists would prefer having a biopsy at that stage. But in this specific case, I would not chase these lesions with a biopsy. If the CT scan of the chest is clear, this patient does not necessarily need a PET scan. And an MRI liver, I would basically leave that decision up to the liver surgeon who's going to operate if they wanted to have any additional information. But from what we want to make recommendations at this point, I think we have sufficient information.
Yes, sir. So thank you very much, sir. I would agree with that. In terms of the liver biopsy, I think everyone would agree that there's no need to. There's still a real risk of seeding of the cancer. In terms of the PET scan and the MRI, I think that the recent guidelines, some would I guess it depends on the availability, but I guess an MRI scan, if it's resectable, just to look at the rest of the liver and so on. Greg, any feedback from the audience? Everybody agrees with that?
No questions just yet from the audience, but yeah, that sounds reasonable.
So the audience could feel free to actually weigh in their opinion as well, because we'll be asking questions as we go along. So now both the primary and the secondary are clearly resectable. Clearly it's resectable. I'll have to say that the primary is fairly asymptomatic. But still, the question arises, chemotherapy first or surgery first? Professor Goel and Patka, what would you all think about that? It's not one lesion, it's more than one. Look at the size, the CA is over 200. Professor Goel, can we start with you?
Okay, so definitely both the lesions, both the sites are definitely resectable. Only thing is, there is one large lesion in segment 8 and 3 lesions in segment 5 and 6. So doing a piecemeal excision will not be feasible. The much more standard approach will be is to do a right hepatectomy in such a case. So if the FLR is adequate, then there is definitely a case for doing a synchronous resection of both right hepatectomy liver lesions plus right hemicolectomy, which is otherwise a very straightforward and a surgery with low morbidity. So, but if we do not have adequate FLR, then we would definitely like to first go in and give chemotherapy 3 to 4 cycles and reassess which the liver tumor might have shrunk by that time. And if not, then we can again take a call about going in to do liver augmentation procedures before we do a liver resection in such a case. Being a right-sided hepatic fracture growth, removing colon at the same time of surgery will not add additional morbidity to surgery for the patient. So doing resection of the primary at the same time is possible.
Thank you, Professor Goel. So yes, I agree. So I think what we'll be looking at here is the risk scores. The risk scores for any evidence of micromets, and there are plenty of them. The Fung score and Professor Goel, you mentioned the no linger score and so on. So this patient will definitely have a high score, and this patient will indeed benefit from neoadjuvant chemotherapy prior to surgery. You did preempt my other question, and I think you gave your answer very clear. Synchronous versus stage. I do agree with you. Both the primary and the secondary seem to be in close proximity. So a synchronous resection seems to be the way to go. Anybody else would like to weigh in on that? Professor Patka or Professor Cleary, what are your thoughts on that? In this particular case, synchronous or stage, patient fit, ECOG 1.
Yeah, I don't think that I would view the proximity as a determinant of synchronous versus stage procedures, more the magnitude of the procedure. I personally don't think the patient would need a right hepatectomy. I think I have to go back to look at the scan, but we still try to do a non-parenchymal preserving procedure if possible, as long as none of the major inflow pedicles or middle hepatic vein is involved. Then I think parenchymal preserving should be reasonable, because you may need the right side of the liver at some point in time in the future. I would strongly advocate for a neoadjuvant chemotherapy approach, and it's not actually the liver metastasis that makes me think that, but also we know that right-sided colon cancers have a higher rate of BRAF mutations and therefore have a higher risk of resistance to standard FOLFOX and FOLFIRI chemotherapy. And so for that reason, I think, you know, we have starting to differentiate between left-sided and right-sided colon cancer, realizing the right-sided colon cancers are slightly different animal. But I would definitely push for a synchronous resection after 4 to 6 cycles of systemic chemotherapy, progressing to surgery only if there was a good response to chemotherapy.
Great, thank you.
And Ravi, at this point, a technical question for the liver surgeons there on the panel.
Yes, sir.
Intraoperatively, do you insist on getting the liver lesions out first before the colectomy? What is your approach?
So, Prof, I do have, sir, I do have a question on classic versus the reverse approach, just about 2 slides down, but sure, we could go ahead and answer now. Anybody want their take on that?
So I would address the liver first, actually, because that is a place which very more likely to have bleeding, and and more morbidity. Colonic resection is relatively low risk surgery. So if we are able to achieve a liver resection successfully without much of a problem, this is not a very difficult case, but otherwise also. So we definitely like to go in liver first and then go to the primary. I don't know what Dr. Cleary would like to say on that.
Yeah, I agree that with that, we do the liver first and then the colon for a couple of reasons. One is I agree with the morbidity comments that the professor had stated. Also, remember, you're going to do your liver resection under low central venous pressure. And so there can be some periods of hypoperfusion of the bowel when we run low central venous pressure, as well as obviously the blood loss can cause systemic hypotension. So you don't really want to do that with a fresh colorectal anastomosis in the patient. So we prefer to get the kind of hemodynamic excitement out of the way first with the liver resection. And then once we finish the liver resection, give the patient back some more fluid, raise the central venous pressure and the arterial perfusion pressure, and then proceed with the colon so that the colon anastomosis can be perfused right away.
Great, thank you.
Yeah, that's been an interesting procedure, because with one of our liver colleagues who we do combined robotic hepatectomy and colectomy at the same time, the low CVP and obviously different positioning. It's a reverse Trendelenburg, steep reverse T for the liver resections, and then going into T-Berg for the colon resection. So these can be quite interesting hemodynamically, and you have to have a good dialogue between the two teams as to what's the best approach.
So I'm glad that we all agree that we do a synchronous resection, because this is what it is I did. This is my version of a cells. Well, at least this is the single incision part of the cells. So this patient did well. So, you know, as we could do in these panel discussions here, we could change things up a little bit. So what if the primary wasn't in the hepatic flexure? What if we moved it into the sigmoid? So it's now diametrically opposite to the liver mets. Professor Cleary, you would have alluded to it, does make a difference where the primary is. If we're doing this open, the incisions might be very different. A midline here, maybe a coccus on this side. Professor Saklani, can I get you in on this? Would you still consider, I mean, in combination with the liver incisions as well, would this be a synchronous resection? Would this now be a stage? Would doing it laparoscopic help at all? What about if we do both in laparoscopic, and maybe Professor Cleary could also give a take on that? Did we sort out the audio with Professor Saklani? Okay, I guess not. So, Professor Cleary, can I ask your take on that? We have moved the primary to the sigmoid. I will now call this case 1 prime. What do you think?
So thanks. That's a good question, and I think the proximity is not the issue, but obviously you increased your risk of postoperative anastomotic complications with a left-sided versus a right-sided resection, and so I think that we tend to do these combined procedures through a long midline incision if we're doing them open. And I've been using midline incisions for liver resections more and more commonly, and getting away from right subcostal incisions and Kluger incisions. I think that there's also times when the colon might be feasible laparoscopically or robotically, but the liver has to be done open. And so that's a time when we'll actually do the colon first and then do the liver open, just because we can save the patient some incision. I think the only thing you have to accept is that when you do a combined procedure, you have to accept that the morbidity is going to be higher and your risk of anastomotic leak is higher. So I would have a lower threshold to defunction the anastomosis with a loop ileostomy if I was doing a sort of a low anastomosis at or below the peritoneal reflection in the pelvis.
Great, I agree. Thank you, sir. So just in the interest of time, the other question that I would have, let's say the patient is not fit enough to have a synchronous resection. Let's say we do have to have a stage of the colon and a stage for the liver. Primary first or the secondary? So are we doing the classic or are we doing the liver first approach? Professor Goel, can I don't know if Dr. Patkar is on?
Yeah, we have Dr. Patkar on as well.
Okay, yeah. Let's get on things.
So in this case, the approach would be decided about depending on how symptomatic the primary is.
So let's say it is fairly asymptomatic. So asymptomatic primary, and both the primary and secondary are resectable.
Yeah, so if the primary is asymptomatic and you've given the initial chemotherapy and the tumor has responded, if a synchronous resection is feasible, the functional liver is adequate, then it would be a synchronous approach. Otherwise, in this case where the bulk of the tumor is on the right side, it's going to entail a right hepatectomy. We can do the liver first approach, address the liver first since the primary is not symptomatic, and then come back to the primary at a later date.
How about if I just change things up a little bit, and I'll call this case 1 double prime. I've increased the size of the liver lesion and make it a lot closer to the cava. Does that help in any way to make a decision?
So it all again depends on the amount of liver which is going to be left behind and the whether we're going to have a functional liver which is adequate. If the functional liver is adequate, I don't think that should be an issue. We can tackle the cava intraoperatively also. That shouldn't alter our approach.
But also, Ravi, just to add here, since you're changing scenarios, one should also factor in that intraoperatively as well, things might be different. If the liver resection, for example, turned out to be more difficult than anticipated, or you had more blood loss, you would certainly have planned that you might actually now do 2 separate procedures. You bail out, get the patient safe, then do the second procedure. So please do, this is not something you've planned to go for a particular process, but that process can also change because that is very important.
Yeah. If the patient is not doing well, you shouldn't go on and do the second part of the procedure. So I think that's how the take home there is that we go for the one that is at risk of becoming unresectable or symptomatic, and we go for that one first if we have to do a stage sort of procedure. And of course, as Professor Shukla said, you have a plan, but if intraoperatively the patient is not doing well, why proceed to the second part of it? You could always lift a fight on another day. Is that the take home? So good. So I'll call that case 1. I think we covered all of the 4 objectives there, which is the workup, the chemo first versus the surgery first, synchronous versus stage, classic versus the reverse. Right, I will just move on. So this is a fairly easy case. It's a warm up. I want to move on to a more challenging case based on a true story, actually, an ongoing case. 60-year-old male, very fit, ECOG 0. He has had ulcerative colitis now for the past 25 years, but now he has rectal bleeding and tenesmus, low rectal cancer, just 5 centimeters from the anal verge, colonoscopy, no other lesions anywhere else. Fully differentiated adenocarcinoma KRAS in this case is wild type, so there is not a mutation of the KRAS. CA is quite elevated, not as high as before, but 150 in this particular case. So we went on to do, in addition to other things, an MRI of the rectum. You could see some of the tumor going into the mesorectal fat, just about for a few millimeters. So I'll call that a T3B. Some suspicious lymph nodes, but the CRM, the mesorectal fascia, is definitely free of tumors, so there isn't any threat of the mesorectal fascia. This here is a CT scan, and I'll just play it here. So CT scan just is normal. This is a huge lesion in segment 1 in the caudate lobe. It's a button impinging. I'm not too sure what other adjective that we have again, but we got about many adjectives that we have. So this is involving the cava, right? We move on to the MRI of the liver. So in this case, Prof. Shukla, we did move on to MRI of the, we did move on to MRI of the liver, and playing the video here. Other lesions cropped up, look, segment 4 of the liver, segment 2, another one in segment 4, superficial in segment 4 as well. You know, in segment 7, it looks like that was a small cyst that you saw. This again is another simple cyst, not to be concerned about. Segment 3, others in maybe segment 5 and 6. So the liver in this case, apart from that big lesion in segment 1, which is involving the cava, also have other diseases and you know, throughout the liver. So just as, again, as an illustration, just to be able to conceptualize things when we have a lot of information, a resectable low rectal cancer, MRF is free, lesions in segment 2, 3, 4, A and B, and scattered as well. Very small lesions, I should say, yeah? Maybe about 5 millimeters is the average size, but the one in the caudate lobe is quite big and encroaching into the cava. So simple question first of all, Professor Shukla, maybe I could ask you, and Craig, maybe you could ask the audience as well, get them to participate. You know, so we have pushed the boundaries on liver resection over the years, pushed it and pushed it. But despite all of that, would you, in terms of your intent, would you ever say this is curative, or this will still be a palliative intent?
So I think this patient has you know, many challenges.
Yes.
So based on the colonoscopy report, it seems like the colitis is the least of the issues, even though that may be the cause for the rectal cancer.
Yes.
But having said that, I think in a T3N plus clinically staged rectal cancer with what at this time seems to be unresectable liver metastatic disease, you would really be pushing with chemotherapy and chemotherapy and chemotherapy.
Yes.
You try to get as good a response on that rectal cancer as you can afford to get. By all accounts, you know, this is a patient in whom you might even be considering, if there were no liver metastases, would this patient be someone who can go into a wait and watch if you had complete clinical response for the rectal cancer? Because of the UC, because you're looking at surgical, not only proctectomy, like a total proctocolectomy. So you're looking at very different and complex questions as to dealing with only the primary. When you throw in the mix of the metastatic disease, you know, it's a challenge, but once you give chemotherapy, we'll again have all our liver surgeons look at this as the tumors shrink.
Yeah, so Prof, I think you may have seen my slides before. Those are the next couple of questions I will be asking, but we didn't share. So yeah, yes, sir, I do agree. And this is the last ESMO guidelines on this on 2016. And at the end of the day, I think most people have to agree that this patient will not do well, and we will be thinking along the care of palliative chemotherapy and chemotherapy and chemotherapy. And I thought this was a good statement to make. And there's always a balance, a fine line of what is technically feasible and oncologically sensible. Sometimes not because that we could take it out, it makes oncological sense. But we will see how things pans out in the end. So yes, this patient did indeed have his first cycle of chemotherapy, Capiox and bevacizumab. Unfortunately, this patient performance status went down significantly, diarrhea, and more diarrhea, about 10 times a day, abdominal pain and PR bleed. His colitis flared up significantly. Now he has a pancolitis, grade 4 toxicity. Main problems are now in the colon, became very dehydrated, went into AKI. But with the discontinuation of the chemotherapy and commencement of the steroid, things has improved. It's now 6 weeks down the road, so the bevacizumab is now out of the system, and his ECOG status is 1. Is Professor Saklani on? If he is on, I'd like to bring him into the fray. Yeah. If not, anyone could probably take this. I guess Prof. Shrikhande will have to take this. So, is there a role for palliative colectomy or palliative pan-proctocolectomy? Just because Prof. Shrikhande, you mentioned that obvious treatment will be chemotherapy and chemotherapy and chemotherapy, but it seems the gastroenterologists feel uncomfortable with the colitis. The medical oncologists feel very uncomfortable to give him any more chemotherapy. The patient himself feel uncomfortable to get more chemotherapy until something happens to the colon.
But is this patient receiving biologics for the UC? Is the UC being adequately managed?
Right. So,
medically?
Yeah. No, it wasn't managed well at the time. No.
Because I guess that's really going to dictate what's going to happen with the chemotherapies, good control, medical control of the colitis. And if that fails, then you have no option but to offer surgical intervention for the colitis, which will then enable treatment of the cancers.
And would you go, so this is a very low rectal cancer, would you go as far as doing a pan-proctocolectomy on this patient with an end ileostomy to allow the patient to have palliative chemotherapy?
Yes, one of the guidelines in patients who have metastatic disease, they would be patients in whom you would possibly not consider making pouches. So you would do a total proctocolectomy with an end ileostomy. Given the case that there is also a low rectal cancer, I think this patient will do, you do not want this patient to have any prolonged recovery or complications from the colectomy and the pouch. So getting this patient a total proctocolectomy and an end ileostomy will then enable treatment of the liver disease.
Good, thank you. Craig, I don't know if anybody in the audience had any take on that. And Craig,
yeah, that's good.
Time as just to keep me in check, as I know it's quite late in India.
Probably sure soon. Yeah.
Right. Okay. So we did change. He did have let's assume he did have a pan-proctocolectomy, and we did change the chemotherapy now to FOLFOX as opposed to the Capiox. So there's less GI toxicity. And we just asked the liver surgeon. So after the chemotherapy, the response has been great on the right side. It is not a button, the cava so much, but it is still, onto the cava. It is actually, basically impinging onto the cava, whichever word that we want to use now. So he has responded. What do we do now? Do we continue more chemotherapy with a palliative intent, or should we do something more? What about things, Professor Goel, would you be able to help us there? And Professor Patna, whoever wants to weigh in on this. Why can't we be aggressive and say, okay, let's do a left hepatectomy, borderline resection, replace the cava, and ablate the rest of the lesions? You alluded to the collision trial for RFA. I know there's things on the Lawa trial with microwave and so on. What do you think, Professor Goel?
So since the disease is still limited to liver, I would be inclined to go a little bit more aggressive in liver in absence of any extra hepatic disease. So a lot of options. The caudate lesion is the only one which is big compared to other lesions. So you can actually have, which I did not discuss, do a Deb-Ire test for that caudate lesion to shrink it further. Yes, you can also do a staged hepatectomy, the two big lesions in left lobe, which can be easily removed by a left lateral hepatectomy. And then you can give further chemo. You can put fiducial markers in the rest of the lesion for ablation later on. But surgery upfront or surgical resection for all the lesions, I would not advocate. I would be more inclined to use liver-directed therapies plus chemotherapy to manage the multiple liver metastases in such a case.
Yes, I think most people would agree. Might want to continue some more of the chemotherapy. Let me just change things a little bit as I do, just to make it a little bit easier. Suppose his initial scan showed that how the right lobe did not have any disease at all. So everything was limited to the left lobe, but of course the Kiva was still involved. And he is responding to chemotherapy. Would you now feel more comfortable in doing aggressive type liver resection on this patient? Again, a left hepatectomy, chordae lobe resection, and replacement of the Kiva. Professor Padmore or Cleary, what you all think? I guess what I'm asking here is that if you could gain R0, are you prepared to go all the way?
Yes, I think in this patient, in this case, when you've changed the scenario where we are probably looking at an R0 resection via doing a left hepatectomy with a caudate lobe resection and a Kiva replacement, there may be a case. At the same time, he should actually have received his optimal cycles of chemotherapy and to judge the maximal response and then probably go in. And we also have to weigh the benefits of doing a major hepatectomy with the number of chemotherapy cycles that the patient would have received.
The FLR is
yeah,
absolutely 100% agree with that. Professor Cleary, you agree?
Professor Cleary just had to go.
Yes,
so, yeah.
So all right, so I know how to direct the questions there. Not a problem. All right, this will be the last scenario, and I'll call that case 2 double prime. So after numerous cycles of the chemotherapy, this is what started to happen. The lesions started to disappear. Well, and we are not seeing any more lesions at all, apart from this one still large lesion in the caudate lobe that is still abutting the Kiva. So all we are left with, when I say all we are left with, from a radiological point of view, all we are left with is this lesion in the Kiva. What now? I'm assuming that's how you'd want to do a PET scan to make sure that out there is nothing else. But I mean, in terms of a disappearing liver met, how comfortable do you feel in major resection and leaving these DLMs, as they call it? I'd leave that to anyone in the panel to take that. That's the last.
So our philosophy has been, I mean, especially in this case, if you really look at the lesions, they are quite widespread in different part of liver parenchyma. So to go ahead and do blind hepatotomies for all this lesion, even if you have ultrasound guided, would be doing too much for a patients where the lesions have disappeared or responded to chemotherapy. What we would do is probably allow these lesions to appear. Patient has to be on chemotherapy. We can definitely address a single lesion by multiple means. You can resect, you can do RFA ablation since it has shrunk in size, or you can even radiate this lesion if you want. And as and when the lesions appear on chemotherapy or later on, we would address those lesions on their own merit, provided the patient remains controlled in terms of not manifesting with extrahepatic disease or metastasis at any other site.
Okay. So yes, I think that's a good point. I think that the take-home message is that not because the lesions have disappeared, not because there's a complete clinical response, that in no way equates to a complete pathological one. Any other thoughts from anybody else in the panel about what to do here?
So since these lesions are widely spread, it makes justifying a blind hepatectomy quite difficult. But if suppose they were limited to a part of the lobe which could be later on resected with lesser morbidity, maybe there's a case for doing a blind hepatectomy. And as someone has posted in the chat box, that there may be a role of treating them by other liver-directed therapies, probably a chemoembolization or even radioembolization at a later date, since they were bilobar and quite widespread.
Absolutely. Good. Okay, so thank you very much. That will be the end of the panel discussion. So I want to sincerely thank everybody in the panel for their time. Are there any final words from anyone else in the panel? If not, I would want to thank you all for your invaluable contribution, Professor Shukla, Goel, Patka, and Cleary. And I hope that Professor Saklani will come in soon. It is quite late in the day in some places, so I think we could virtually, right, all have a drink together. These are beers from all of the regions that represent us, Canadian, Indian. This is ours here in Trinidad. The other beer that we could have, and this is the namesake that have us here in the that we're in.
Ravi.
There's not a problem in sharing a Corona or two. I would really want to thank you all for your time, and cheers to all of you. And most importantly,
Yes.
I would like to see you all in the Caribbean, where we could show you our culture very soon, face to face.
Yes.
Thank you all. I will now
Thank
hand
you.
you back.
Thank you, Ravi. Thank you.
Thanks
Thank
a
you
lot,
so
Ravi. Thanks very much to all our panelists and all our presenters. Professor Saklani unfortunately had some technical issues, so he extends his apologies for his presentation. So we'll wrap up now with Amiel, Dr. Aria. He's our secretary, and he'll give our vote of thanks. Thanks again.
Thank you, Greg. Can you see me?
Yeah, good to go. Yeah.
Just a brief announcement. There will be a feedback form provided that you will receive via the chat. I think the link is there already. So anyone who's interested in attaining CME credits for the meeting could fill that form, and you'll be able to get your CME credits there. So a pleasant good day to all who have taken time out of their busy schedules to attend this meeting of the Caribbean chapter of the American HPB Association. It is my sincere honor to deliver the vote of thanks for today's proceedings, and in so doing, bring our conference to a close. I would like to start by thanking the Almighty for this opportunity to assemble today in good health and of sound mind in the midst of the crisis that is being faced by many due to the ongoing COVID-19 pandemic. We are pleased to have in attendance a diverse cross-section of international and regional attendees, including our own panel of renowned experts from around the globe. I would also like to acknowledge the organizers and all members of the Caribbean chapter, with special mention of Professor Shamir, Cawich, and Dr. Ravi Maharaj, who have recently assumed the role of President and Vice President, and have relentlessly shown their support for this endeavor from its inception. Sorry. Our efforts to ensure that this conference was able to successfully materialize were enhanced by the staff at the Trinidad and Tobago Medical Association, who were essential in helping us gain accreditation of the AACME, as well as facilitate the registration process. And we thank them for all their hard work and support. I must also mention the staff of the University of the West Indies, Department of Surgical Sciences, as well as Head of Department, Professor Dan, who supplied us with the platform to host today's event. To all our presenters and panelists who have honored us with their time and effort today, I cannot emphasize enough how significant your contribution has been. To be able to learn and interact with such titans of their respective fields was an immense privilege. Our esteemed speakers from Canada, Professors Elijah Dixon, Oliver Bathe, and Sean Cleary, your presentations were both informative and enjoyable. I was most inspired by the ease at which you were able to deconstruct such complex topics and deliver them to us all in a form that was easy to digest. Indeed, this is a feat achieved by only the most seasoned of practitioners, and your contributions to today's events have been received with the utmost admiration and gratitude. To my dear friends from the Tata Memorial Hospital in Mumbai, Professor Shailesh Shrikhande, who unfortunately had to leave early due to a prior commitment, Professor Mahaesh Goel, Professor Shara Patka, and Professor Avinesh Saklani. Thank you, first of all, for allowing me to be your guest over the last year, and more importantly, lending your experience and expertise to the surgical community of the Caribbean, as we continue to seek excellence in the fields of HPB surgery and surgical oncology. Certainly, the chance to work with you all was an intense catalyst for the inception and planning of today's conference, and your contributions will not soon be forgotten. Your respective talks were brilliant, and the clarity with which they were delivered represent a true reflection of lives and careers dedicated to education and delivery of highest levels of cancer treatment. We ardently look forward one day to being able to accommodate you all to our shows so we can commune in person. To our guest panelists, Professors Parul Shukla and Michael Kluger, who are no strangers to us here in the Caribbean, we thank you for your long-standing commitment to surgical education and mentorship in our region and involvement in today's meeting. Thanks again to our case presenters, Dr. Ravi Maharaj and Dr. Don Major, for a series of interesting cases and stimulating discussion that perfectly complemented their respective sessions. Finally, I'd like to thank all attendees for your interest and participation in today's meeting. We actually received over 300 applications for today's conference, and I know it wasn't reflected in the participant list because many of you have opted to hold joint viewing sessions. So you have had quite a turnout today, and I'm hoping that we all continue to meet and learn together in the future. A good day to all, and may you all remain safe and in good health. Thank you.
Thank you.